speak for at least half a minute. She will tell you, doctor, oh my God, I cannot even study. I cannot study everything. I cannot concentrate. I cannot recall anything, and my exams are coming closer, doctor. Doctor, please help me. I do not need to be that exhausted. I'm going to fail, and I used to be a good student. Please reassure her. We are all here to help and support you. Move to the examination, please. In the examination, it's important to verbalize the tummy examination as well, and the respiratory examination. The vitals here may show tachypnea. Why tachypnea? Because this is cosmal breathing. Cosmal breathing secondary to DKA, like rapid shallow breathing. Okay, now move to the investigations. Which investigations? Routine bloods, urine, very important, routine bloods and urine here. These are the core of diagnosis. Routine bloods including blood sugar is a must here, and ABG, please do not forget to verbalize the ABG and the urine. Those three compartments are the most important. Why? Because the blood sugar is high, and the ABG will show metabolic acidosis, and the urine will show 3+ ketones. So now I can say that this is diabetic, high sugar, keto due to urinary ketones, acidosis due to metabolic acidosis. Move to the disclosure of the diagnosis. Do you have any idea what's going on? No, doctor. Actually, you are having diabetes mellitus. What is this? It's a condition where the blood sugar is a bit high due to abnormality in the insulin, which breaks down the blood sugar. Oh, doctor, so how are you going to treat it? Well, we are going to have a variety of options, but the problem is that actually now you developed one of its complications, which we call diabetic ketosis. What is this, doctor? It is a condition in which it is a complication of the diabetes, as I said, in which the blood becomes acidic. The blood here becomes acidic usually because of the breakdown of the fat, which leads to the production of something called ketone acid or ketone bodies. Why, doctor? Because actually we cannot break down the glucose due to deficiency in the insulin, as I told you. Oh, so what I'm going to do right now, or why did I have it? Actually, it's more family history. We'll tell her about family history. What are you going to do for me? We need to keep you in the hospital. Doctor, I do not want to stay in hospital. This patient will have a conversation with you at least half a minute for hospital stay. She does not want to be kept in hospital. Okay, why? Because she's having her exams in 3 days and staying in the hospital will make her late. So please here, tell her, I can understand it can be frustrating to stay in hospital, but you know, you told me that you're a very good student and you cannot focus on your study. Actually, what you are doing right now is to help you focus better on your study. That's why we need to give you the best possible treatment as soon as possible to back to your exams and perform and ace them very good or very well. Okay, doctor, I will stay then. I'm happy to stay. By the way, I spent the last of the station telling her about the management option or the treatment option, which is, what is the treatment option? Number 1, IV fluids. Number 2, insulin to correct the blood glucose level. When you give insulin, there is a chance of playing or disturbance in the blood potassium. Insulin antagonizes the potassium. So what I do, I'm going to monitor the blood potassium and we may give her potassium injections. And unfortunately, the potassium affects the heart. So I need to monitor the heart by doing ECG. And you know, when someone is having diabetic ketoacidosis, sometimes there can be a problem with the urine. So I need to monitor the urine output. Okay? Okay. This is the station so far. IV fluids, insulin, potassium, heart, and urinary output. If you ever have time in the end, you can tell her we are going to monitor your blood glucose in the next 24 hours, adjust the insulin dose according to it. We are going again to monitor your urine output. Okay, one important thing. In the beginning of the station, if she ever gave you history of nausea and vomiting, even if 2 or 3 times, do not also forget to ask about dehydration, which is a red flag. Sometimes she can give you, she did not give me nausea or vomiting. She told me about tiredness, oliguria, and polydipsia. But you know very well that nausea and vomiting can be a sign of diabetic ketoacidosis together with epigastric pain. So if she ever gave you nausea and vomiting, any station in PLAB 2 in which the patient gives you frequent diarrhea or frequent nausea and vomiting, please do not forget to ask about dehydration. Dehydration is very important. It is a red flag and life-threatening condition. So the difference between this station and the old one is that this station or this patient is the first time diabetes mellitus presentation. But in the previous ones, she was already diagnosed with diabetes mellitus. So the old scenario will tell you that this patient is diagnosed with type 1 diabetes mellitus, which they are receiving insulin since 10 years. Same presentation, same everything. But the presentation here is not tiredness. She's presented with tummy pain and polyuria or polydipsia. No problem, Dr. Safa, it's fine. So the presentation in the old scenario is tummy discomfort and polyuria or polydipsia. So the only difference is that in the old scenario, you will know that she's having diabetes before entering to the cubicle. But now you do not know that this is diabetic. This is first time presentation. This patient is 16 years old. The old patient is actually, or the previous station is, the previous station is 42 years old. Will establish diabetes mellitus. Okay? Okay. But good news is that only the new scenario comes. Believe me, you pray that you give this a station. She's, or he, and by the way, recently he became a male, a young age male. The simulator in this station is quite cooperative, and your interpersonal will be quite good. Okay. So let's move to another station, one of the EC station as well. I don't know why some people are having problem with this station. Actually, I know at least 3 or 4 people who failed this station for no reason. This food poisoning station. Okay, now we are going to explain, or we are going to speak about the food poisoning things. Food poisoning scenarios are quite interesting because all of us have experienced them in their lives or with their patients. Why? There is a crucial difference when it comes between the food poisoning and the hepatitis, which is food poisoning usually all the vitals are normal, all the investigations are normal, and everything around you is normal. The only thing could be bacterial or stool culture. The stool culture usually will not come in 2 days. It takes at least 3 days to come. So food poisoning is a clinical diagnosis. While I cannot say that this is hepatitis unless I'm having test results. I hope you got my point. Hepatitis is usually lab diagnosis, not clinical. But food poisoning is clinical diagnosis. And the onset of the diarrhea is it's quite near diarrhea. Just started 1 day ago. Okay, let's start with the food poisoning station. Your task says that you are FY2 working in A&E. The patient is coming with diarrhea and vomiting since 3 days. The patient here is 30 years old lady, okay, and special note, the vitals here are quite normal apart from some fever. So there is low grade fever. This is the only positive thing. It's mentioned in the task. Special note, the food poisoning is a notifiable disease. Why do they tell us about this special note? You will get to know now. One thing, if you forget to mention this thing, that the food poisoning is a notifiable disease to the patient, you may not pass this station. Because this is part of your task, but in disguise. You will get to know why right now. When you enter, she will give you the history of diarrhea and vomiting, which started 3 days ago. When the patient is giving me diarrhea, I need to ask since when it started, how did it start, and has it changed? How many times do you go to the loo? Now, speak about the diarrhea itself, the stool itself, in terms of amount and color and smell. Amount, color, and smell. This is for the stool itself. And the same for the vomiting. Since when it started? How did it start? Has it changed? How many times or how often? or how many episodes, and ask about the vomitus itself in terms of amount, color, and content. Okay, Dr. Masi, when someone is presented with diarrhea and vomiting for 3 days, what is the most important thing to ask about here?
Dehydration.
How will you ask about dehydration?
Do you feel dehydrated
Really,
these days?
really, and the patient will tell you what is the meaning of dehydration, doctor. How can I know if I'm
Do you
dehydrated?
feel thirsty? Do you feel thirsty?
Yeah, you feel thirsty these days too much, or are you able to? Sorry, do you feel thirsty these days, or or simply have you noticed any decrease in your urine output these days? One
Mm-hmm.
question: have you noticed any decrease, or do you feel more thirsty these days? This is two questions to rule out the dehydration. Very simple. Okay, now I ruled out dehydration with diarrhea and vomiting. Now ask about other associating symptoms like fever. She will be feverish. Ask about tummy pain. Usually she's having like dull aching tummy pain around her tummy or all over her tummy, like any gastroenteritis we used to have. Okay, okay. You can ask also about other things, maybe like headache because of the fever. Okay. What are your differentials here? We asked about the red flag, which is the dehydration. You can also ask about other things. That can be related to the vomiting and the tummy pain. Like what? You can simply ask about the UTI because it can be associated with tummy pain and vomiting as well. Okay. You can also ask about PID. PID is usually presented with constipation, but it can be DD here. Just ask about the period. When you ask about the period, you're good to know that it is not PID. So again, dehydration and UTI are the most important differentials. Now move to the PMH. Any previous episodes? No. Recent health. Have you had any fever or fluoride illness recently? No. Did you have any bouts of alternating diarrhea and vomiting, diarrhea and constipation recently? No. Why? Because I need to exclude acute exacerbation of IBD. So ask about any alternating episodes of diarrhea and vomiting, diarrhea and constipation, sorry. Now move to the medical conditions. This lady is very healthy. Do not take any medications. She does not have any allergy. And the good news is that the family history is conclusive here. Why? Because she and her partner and their daughter, they took sushi in the restaurant 3 days back. Raw sushi, of course, raw, which means that it is probably gastroenteritis or food poisoning. Now ask about the lifestyle. And by the way, when she tells you that they got the same meal, ask if they have similar symptoms or not. Unfortunately, she's the only one who's having the symptoms right now. Okay, they had symptoms as well. They had symptoms, but it settled down in their case. But in her case, they did not settle yet. Anyway, the important thing is that they share the same plate and they have the same symptoms. Now ask about the lifestyle. Okay, it's not conclusive because it's acute problem. You can focus more on the diet here and the lifestyle and the job as well. So, yes, Dr. Safa. So the daughter did not eat the same food. That's good. This means that she and her husband shared similar symptoms, which means that it's probably food poisoning because of the food itself. Now, sympathy, empathy, very good. Sympathy, empathy are very important in any station when the patient is worried. And the good point is that Dr. Safa reassured her. When it comes to the investigations, okay, you will do routine bloods and urine and stool as well. Do not forget about the stool. The examiner will tell you that the stool culture is waiting. Okay, from what you told me, it seems that you're having a problem we call food poisoning. It is infection in the gut due to contaminated food, most probably due to the sushi that you have taken in the restaurant a few days back together with your partner. What are you going to do for me? Usually this is self-limiting condition. However, we need to give some general advice to you. and we will be doing some investigations. One of them is a stool investigation, which we are waiting for its result. We have done some investigations. One of them is a stool, which we are waiting for its result. Okay, what are you going to give me, doctor? Usually it is self-limiting condition. However, we need to give you some few advices. Like what? It's important to maintain proper fluid intake to compensate for the fluid loss due to the diarrhea and vomiting. This is number one. It's important actually to drink at least 500 ml to 1 liter of fluid per day, like water, to compensate for that and prevent dehydration. Number two, for the fever, we can prescribe here some antibiotic or some medications to lower her body temperature, like the simple analgesics actually. Number three, regarding her food, it's very important to maintain healthy, balanced diet, especially in these days, to focus more on the steamed food and soup, rather than the heavy food or the heavy meals and the fried meals. Okay, because the other meals like the fried meals and the caffeine as well can irritate her gut. Okay, number four, regarding the medications, it's not advisable to prescribe medications. However, if she's having some occasion, like maybe any wedding or any party, we can prescribe for her antidiarrheal, loperamide, which decreases the gut motility. Okay, doctor, won't you give me antibiotic? You will tell her that this condition is self-limiting, is that it does not require antibiotics because antibiotics as well will be having some side effects, and we usually prescribe it for the bacterial infections only. Doctor, but why it's not bacterial? You will tell her most probably in your case it's viral. However, we are waiting for the results. We are waiting for the results of the of the stool culture to confirm. Okay, one more thing. You finished the station right now. Now you will tell her that you told me that you took this sushi from this restaurant. May I know what is the name of this restaurant? She will tell you, why, doctor? It belongs to one of my friends. You will tell her, I can see that you're quite concerned. But the thing is that actually, don't you see that, or I'm sure you agree with me. I'm sure you agree with me that this incident can happen to other people as well. So we are obliged by law to report it to the environmental health officer. So here you will report this incident to the health officer. Health officer is a sort of like office which requires or which investigates the health compliance of different restaurants. So they will investigate it. So you report this to the local health officer, and they will do their research and their investigations to check the health standards of this restaurant to prevent this incident from happening to other people as well. Okay, doctor, thank you. She will be convinced in the end. When you say about other people, she will be convinced. We are done with this station. This station you can finish
Hello.
it. Yeah, hello?
Excuse me. Sorry to interrupt, but
No, fine.
I had this during my exam,
Yeah,
and she wasn't convinced when I explained to her about. She had these very distressing symptoms, and she was really upset about them. So I said to her that other people could suffer the same sort of symptoms, and she still wasn't convinced. The restaurant was owned. She said that the restaurant was owned by her friend's husband. So she didn't want to take their name. So then I said to her that maybe the place they were sourcing their food from it was actually the cause of the infection, and we had to trace that because they might be sourcing their food. Other restaurants might be taking the food from them, and that might be causing the infection. So to trace that, we needed the name of the restaurant,
yeah.
and we would do it anonymously. And then she said okay, and she'd give the name.
Okay, perfect.
So yeah, that's it.
So usually you will tell her in any patient, it is very good that you brought this point because in any patient in PLAB 2, the HIV patient, any infectious case, you have to encourage the patient at first to report or to inform us about the name. Okay, if the patient does not inform or if the patient does not report, we may need to report it by ourselves. So in the HIV, you will encourage the patient to do that. To, for example, to inform the partner to come for a checkup. But if they do not accept, we are going to inform them on their behalf anonymously. Here, you can do that as well. You will encourage the patient to report it. But the problem is that it is belonging to her friend, the restaurant. So what we can do, just tell us the name and we will report anonymously. Doctor, but I do not want any harm to them. Now you can tell her that it can happen to other people as well. So you can tell that it can happen to other people, so we need to report it. Okay, and we are going to report it anonymously so that nobody will know about that. Okay. Okay, so when any patient is reluctant, say the thing anonymously. First of all, you need to tell them the reasons that you need to report to prevent this from happening to other people. And the second reason is that we are going to report it anonymously, so that the patient will be reassured that nothing bad will happen to them. I mean, the owner will not know that the complaint did not come from them. Okay, now let's move to the next station. I think this station was quite easy. The only trick here is to tell the patient about the restaurant. Okay? Okay. Um, Give me 1 minute, sorry. Okay, let's move to the next station. Right now we covered 3 stations in less than half an hour, or in half an hour, exactly. You feel that the pace is fast? If anyone has problem with the pace, let me know now. Or if anyone is struggling to understand or to follow, let me know. Let me know now. Please tell me. Anyone has any problem? Anyone has got any problem, guys? I think Dr. Wala did not come, and Dr. Samia has not come as well. And Dr. Mahdi is flying now. And who else? Dr. Muniba, how are you?
I'm good.
So, Dr. Muniba, tell me, what if the patient is presented with, if the patient is presented with, for example, constipation after surgery, after a hip surgery? If the patient is presented with constipation after a hip surgery, you know that after hip surgery, we usually need to take strong analgesics, right?
Yes.
And after the surgery, the major surgery, the patient will not move around.
Yeah.
I mean, he will not be likely to move around because this was a major
Yes.
surgery in the hip, okay?
Yeah.
And
Yes.
after major surgery as well, there could be some, the patient diet may not be very balanced because sometimes there can be like the patient needs to stick to healthy balanced diet like fruits and vegetables, but they may not be compliant to it.
Yeah.
So you think what could be the reason for the constipation post-operatively? I give you the easiest question right now. For any post-operative constipation.
Yeah, it could be multiple reasons. Number one, the patient isn't mobile.
Yeah.
Number two, patient is being given analgesics and like she could be having codeine, which causes constipation as a side effect,
Yeah,
and
perfect.
plus because of diet, as you said.
Okay, perfect. Thank you, Dr. Muniba.
Okay.
Thank you. So now you cover the station, the post-operative constipation. In the post-operative constipation station, this is the most interesting station on PLAB 2. Why? Because you will finish it in you will finish it in 5 or 6 minutes ultimately. Why? There are 2 scenarios for it. One scenario, you will talk to the nurse, and the other scenario, you will talk to the old lady. The old lady scenario is very nice. she's an old lady who's very kind and slow, very kind and slow, and she's even sometimes touching you by her hands, like saying, doctor, I'm really embarrassed. I cannot go to the room. I'm really embarrassed about that. So all the station will be sympathy and empathy and reassurance. You are more likely to score 4 in the interpersons in this case, and your data gathering will be quite concise, and your management is very easy because all of us have got constipation at least once during our shifts because of the stress. So probably all of us know about it. Okay, doctor, first of all, the task, Dr. Rumi, the task. You're FY2 working in surgery department. I know we are discussing medicine, but this station is quite related to the medicine, not about surgery too much. So you're FY2 working in surgery department. The patient is old age lady. She was presented with hip replacement surgery 4 days back. The surgery has been done and no complications. She has been given She has been given painkillers, or she has been given analgesics, codeine, for her post-operative. And now your nurse colleague has got some concerns regarding her bowel habit, the bowel habit of the patient. Talk to the nurse colleague and address his concern regarding the management of the patient. Special note, the patient is not in the cubicle. So there are two scenarios. One scenario you will talk to the lady, and the other scenario you will talk to the nurse. Let's discuss the hard one, and the other one will be just, it will be nothing. It will be almost similar to the other one. Okay, so when you talk to the nurse, she will tell you that the patient is having constipation since 3 days. This is the concern of the nurse. She will tell you that the patient has been admitted 4 days ago, and right after her surgery, she has got some constipation. Dr. Manisha, how are you?
Hello, I'm good. How are you?
I'm fine too. Are you ready for a question?
Yes, please.
When someone tells you, Dr. Manisha, that our patient has been constipated since she has been admitted for a surgery, what will be your questions here?
Okay, so from talking to the patient, I'll.
No, nurse. The nurse. You are talking to the nurse.
Okay, so I will ask an open question about talk to me more about what is the problem.
She will tell you, doctor, she has been admitted here in the hospital 4 days ago because she was having hip surgery.
Okay, and so when was that hip surgery?
Yeah, exactly. So now you ask the open question. You will ask about the hip surgery and how the surgery went, and if there was any complications. What else you will ask about?
So then I'll be asking what was that surgery for, and maybe
Okay, slowly, Dr. Major, slowly. Let's try it.
Okay.
Don't worry, don't worry. By the way, you followed Swami, right?
Yes.
Okay, I could guess that. Anyway, Dr. Manisha, let's speak. I don't mind spending 10 minutes in this portion, but I need you to make sure that you are aware how to take history of such challenging situations. When the patient is telling you that, or when the nurse tells you that our patient is having constipation since 4 days, since she has come to the surgery, and after her surgery. So now you are having two complaints. One complaint is a constipation, and the other thing is that she was presented for surgery, right? Now you will elaborate number one, the surgery. When was the surgery? Why did she have the surgery? Was there any complications to the surgery? No. Maybe she tells you that she has got some pain after surgery. Even if she does not tell you that she has got some pain, you know what? You need to ask about does she receive any painkiller after surgery? Because as a doctor, you know that hip surgery are quite painful. They are major operations. So they need to receive painkillers. So ask, did she receive any painkiller after surgery? She will tell you, yes, doctor, she's taking codeine. Now you know one reason. for the constipation, which is a post-operative painkiller, codeine. So ask about the codeine. How much and how often does she take? And does she take it regularly? Okay. Let's speak about the constipation itself. Since when it started? How did it start? Has it changed? When was the last time she opened her bowl? And did she pass any wind? Yes, she passed wind. This question I said in the first class. In the first class, I said that when did she pass wind? This question is very important. Why? Because one news station, which came actually first in my day, 23rd of February, in this station, the patient did not pass wind. So here is different from there. Usually in this station we are talking right now, the patient pass wind, which means that it is not intestinal obstruction. When there is intestinal obstruction, no pass wind. Okay, so this was her bowel habit. What about before that? She will tell you that she used to go to the loo once per day in the morning. When someone is presented with constipation, we need to ask some questions which can be related to it. So by any chance, has she got any diarrhea in between? No. Any tummy pain? Sometimes she tell you yes, and sometimes she will tell you no. If she tells you yes, you will find maybe suprapubic or periumbilical tummy pain. Okay, doesn't go anywhere else, and it's dull aching pain, and it's getting worse. So again, associating symptoms for any constipation are diarrhea and tummy pain. You can also ask about fever and nausea and vomiting, like the previous station exactly. Okay, now move to the past medical history. Has she got any problem, any similar episodes in the past? No. Well, how was her health recently? When you are speaking about constipation, you can ask about UTI. So has she had any changes in her urine, any smelly or cloudy urine? No. Because this is constipation, I have to rule out UTI as well. Any medical condition? No. Any bowel problem? No. Does she take any medications apart from the codeine? No. Any previous hospitalization or surgery apart from this time? No. Any family history of medical condition? No. Mind that she is having only 3 days of constipation. 3 days means acute constipation, so it is not bowel cancer. Okay? Please do not ask about bowel cancer because this is just 3 days constipation. It's not long-standing constipation. Now ask about the lifestyle, which is the core here. Now, before from the history, I got one reason for the constipation, which is codeine. Now, in the lifestyle, I will get 2 more reasons. Number 1, ask about the diet. She may be following healthy, balanced diet, but not enough fruits and vegetables. So you have to be specific. Does she take enough fruits and vegetables and drink enough water? No. Is she physically active? This question is very important here as well. You have to ask about physical activity. If she is quite movable or mobile around, she may tell you no, she is not mobile that much these days. This is one reason for the constipation as well. Does she smoke? Does she drink alcohol? No. She is old lady, so actually no need to ask about 4Ps as well. Okay? By the way, she is a nurse, which means that you cannot ask about the menstrual history from the nurse. So now move to the examination, which is the other core. Now you have 3 reasons for the post-operative constipation. Number 1, the painkiller. Number 2, the physical activity lacking. And number 3, the improper diet and water intake. Move to the examination. Very important to do the tummy examination, and please write with a big highlight. Perirectal examination. Perirectal examination. Always mention the perirectal examination. Dr. Manisha, you will stay with me for 10 minutes after this class. And Dr. Zaid, because I did not stay with Dr. Zaid yesterday. Where is Dr. Zaid? Dr. Zaid is gone. Dr. Zaid, Dr. Zaid, Dr. Zaid is here. So Dr. Zaid and Dr. Manisha, you will stay with me each one of you 10 minutes after the session today. We need to discuss and we need to make you take history from me for separate complaints. You will take a full history from me in 2 minutes. I don't know why and how, but you will do it. Full history in 2 minutes. And Dr. Zaid, you will practice one station with me. I will select this station from the previous stations. But don't worry, I will not practice with you one of the past stations from yesterday because the yesterday session is not completed yet. Okay, and for tomorrow and after today's session, please remind me to arrange you into groups because seriously, you need to start practice from today. Today is the 22nd of April. Some people are having their exams in the end of May. You need to practice at least 5 stations per day. Everyone. 5 stations per day will barely take you 1 hour. I think it's worth your time to practice for 1 hour per day. Okay, let's move to the examination. Please mind that you need to mention the perirectal examination here very well. If you do not mention it, you will miss too much. Tummy examination will show suprapubic tenderness, and perirectal will show hard impacted stool. So probably this woman or this lady is having this tummy pain due to fecal impaction, or she's having this constipation. She was having constipation, which gave her fecal impaction, and the fecal impaction gave her tummy pain. Why? Because after the operation, the gut motility is affected. So the feces are not excreted properly. So they get dried and they are impacted in the back passage, which causes furthermore constipation and furthermore tummy pain. Okay, we need to do further investigations to the patient. Actually, by the way, the nurse will tell you, doctor, I did not do any tummy examination or perirectal examination. Here you can use medical jargon because you can say perirectal examination and abdominal examination to the nurse because she's a nurse, she knows about them. Okay, no worries, we are going to do them together. And then the examiner will give you findings of the examinations. One important thing to consider is the investigations you have to perform, please, at least urine and x-ray. Urine and abdominal x-ray, always at least verbalize them. Because this is a twist that came recently, which came in my day. People who did not mention the abdominal x-ray, the examiner did not give them the abdominal x-ray. So please always mention that. Okay. Fair enough. I think fair enough. Dr. Zaid, it's not necessary here to ask about that, but you can only ask about the period. But the problem is that you are talking to the nurse. How will the nurse know? You can ask about the nurse if she's taking pills or not, if the patient is taking pills or not. But usually, this 4P history should be taken from the patient herself, not from someone else. So when you are talking to the nurse, it's not that necessary to ask about the 4Ps from the patient. Okay, now to move to the investigations, the examiner will keep quiet. But if he asks you which investigation, say bloods and urine and abdominal x-ray. Okay. In the management, you will tell the nurse that she's having fecal impaction. Why? What's fecal impaction? You will tell her that due to the painkiller that she's taking after the operation, reduces the gut motility or causes constipation, which causes the fecal or the feces to be impacted in the back passage. That's why she's having this constipation and this tummy pain. What will we do right now? Okay. In the constipation, there are some medications and some lifestyle advice. Number 1, we need to reduce the dose of the painkiller after reviewing with the senior. Number 2, we need to give her proper water and proper fruits and vegetables. Number 3, we will move her around. So we will address the lifestyle problems that she's having. We'll move her around even slightly to prevent or to stimulate the gut motility. Which medications are we going to give the patient? We are going to give her laxatives. Which laxatives? We can start with osmotic laxatives and stimulant laxatives. Okay, the stimulant laxatives may take little time, so we can give her osmotic laxatives and stimulant laxatives at the same time. We will start them together today. Okay, okay. We can also give her some suppository. Which suppository? It's called the bisacodyl suppository. Stimulates gut motility as well. Okay, okay. Very important thing is that if the medications or if the tablets did not manage, you will do or you will consider the manual as you will consider the enema. And if the enema did not manage, you will consider the manual removal. So usually we do medications in any station. You do medication first, and number two, little bit intervention, and number three, manual intervention. How we do the enema, the bowel enema, you will simply inject some fluid, okay? And this fluid will be injected in the back passage, which will moisten the stool. Okay. And number three, if the enema did not manage, you will consider manual removal of the impacted pieces by your hands. So number one, medications, laxatives. Number two, enema. And number three, manual removal of the fecal mass. That's all? Yes, that's all. Okay, Dr. Ella. So one thing, sometimes this station can be quite tricky. Why tricky? Because the nurse may not give you in the examination that there could be hard impacted stool. So there is no stool infection here or no fecal infection. So what if all these complaints and the patient did not pass any wind and there is no fecal infection? No, suppose even if the patient passed wind, yet still there is no fecal infection. What you will do right now, Dr. Ella, or what will be your diagnosis? Dr. Elvira. Hello.
Yes. I really don't know.
Okay, let me tell you. Very good.
One more time.
Yeah, okay, that's fine. You can mute yourself. I will explain it again because this is challenging. Dr. Maria, you are right. Dr. Maria, you are right. It could be obstruction. Still, you will tell the nurse because actually the examiner will not give you findings from the X-ray or abdominal X-ray. But you will tell the nurse that we need to do further investigation to confirm if it is obstruction, like we need to do the abdominal X-ray. So if they do not give you fecal infection in the rectal examination, you will say that it seems to me it is intestinal obstruction. However, we need to do abdominal X-ray to confirm that. What will be the management in this case? Okay, it will be totally different management. Surgery. Remember, Dr. Lamia, you asked me 3 days ago. What is the surgery 6? 3 in and 3 out. We will pass cannula. We will monitor the urine output, and we can pass nasogastric tube. This is the 3 out. 3 in, we need to give IV fluids. We may need to give painkillers as well, and we may need to give her antibiotics. Those are the 3 in and 3 out for any surgery. Okay, this station, this twist barely comes. Yep, Dr. Yemi. Actually, she will give you the obstruction which started maybe 2 days ago. And in my day, the obstruction started 2 days ago as well in the patient. So do not underestimate this. The 3 out are catheter, cannula, and nasogastric tube. This twist came only twice, or maybe barely, it will barely come. The most familiar or the most common is the fecal infection, because the intestinal obstruction comes at a different scenario and it is a combined station. Okay? Okay. We will discuss the intestinal obstruction later on in the combined stations one day. So these are 2 scenarios together. One is talking to the nurse and one is talking to the old age patient. Fair enough, and very easy, by the way. In this station, I need you to pick up only 3 things. How to take history of constipation, number 1. Number 2, the 3 core or the 3 reasons here are number 1, the improper mobility. and insufficient water intake. And number 3, the medication, the codeine that she's taking. Dr. Zaid, in PLAB 2, you always talk nicely. Even if the patient is going to, I'm sorry to tell you, if the patient is going, wait, I'll stop the recording. Wait. I'll stop it. The subconjunctival hemorrhage. Seriously, I don't know what these guys are thinking about. Why do I bring subconjunctival hemorrhage as one separate station in PLAB 2? Anyway, it happened. In this case, actually, the task says to you that you are FY2 working in GP and the patient is presented with red eye. Can you imagine? Okay. So the patient is presented only with the red eye. Now we will enter to the patient. Hello? Hey, Amy. Your mic opens up, Amy. Okay. So the patient is presented with red eye. This is the only presentation. By the way, this guy is wearing only normal glasses. It's not sunglasses, okay? So this is one difference between this station and the glaucoma if you ever think to confuse them. Okay? One other thing. The other thing is that you're sitting here as GP. Subconjunctival hemorrhage never comes in A&E. So here, the patient will come to GP, while in the acute angle closure glaucoma, it will come in the A&E. He is a guy and he's not a lady, okay? He is a guy. This is another difference as well. It's different? Yes, it's different because the other lady was having depression due to separate from her boyfriend or something. Okay? So now you will speak about the history. What is the history of subconjunctival hemorrhage? Only red eye. So the red eye comes and goes. He first noticed it in the morning 2 days ago, and it's there since then. So red eye which started suddenly, sorry, it is continuous, not episodic. Red eye which started suddenly, maybe 1 or 2 days ago, and it's continuous and it's getting worse. Please, it's getting worse, which made the patient comes here. Is there anything else? Like what, doctor? Now, what are your differential diagnoses for the red eye? Glaucoma. Who's asking? Wait, Dr. Murat, sorry. Okay, it's fine, Dr. Murat. Take your time. Glaucoma. So you will ask about any halos around the light? No, doctor. Any pain in the back of your eye? No, doctor. By the way, I forgot to ask one important question. What is the important question that I forgot to ask Dr. Bina?
Which eye? Both the eyes or one
MashaAllah,
eye?
MashaAllah. I'm proud of you, Jester. That's good.
Thank you.
Okay, so this is the question that I forgot to ask. Which eye? Actually, this question is silly. No, it's not silly. It's important. Okay, so you have to ask which eye. What are your differentials again? Number 1, glaucoma. Number 2, any infection in the eye. You will ask about any discharge. Yeah, exactly. Any infection, Dr. Maria. Like any discharge, any swelling or redness in the eye. Sorry, he is having redness. Any swelling in the eye? No. So those are very enough or two enough differential diagnoses here. You can also ask about any blurry vision or any visual problems. Trauma as well. Very good. Any blurry vision, any visual problems. So red eye associated with number 1, eye pain. Ask about eye pain. No eye pain. Ask about eye pain. Ask about nausea and vomiting. Also ask about any discharge from the eye. Also ask about any injury to the eye. Very important as well. Like the glaucoma station exactly in terms of associating symptoms. Move to the past medical history. He did not have any similar episodes. Recent health, you usually should ask about any flu-like symptoms or any constipation. Why? Because those two things may cause some straining, and the straining, like body straining, and the body straining can elicit the subconjunctival hemorrhage sometimes. So please ask about flu and constipation. Medical conditions, ask about hypertension. It can be related to it sometimes. Any medications like blood thinner? Family history irrelevant. Any close contact with similar problem? No. Here in the lifestyle, it's not relevant. Just ask about smoking, or do not even ask about lifestyle. It's not relevant. It's eye problem. But important to ask about swimming as well. Ask about swimming because sometimes red eye can be due to swimming in swimming pools. Now move to the examination. The examiner will show you a photo of the eye, very red eye. Okay, it's quite normal, and you will see it from its look. You'll know that it's subconjunctival hemorrhage. Very obvious. We all had it one day. No need to do investigations. Actually, this is like clinical diagnosis by inspection even. Those are patients that you're having condition we call subconjunctival hemorrhage. What is this? Subconjunctival means there are a chance of bursting of the blood vessels under the conjunctiva. I said blood thinner, Dr. Ofodeli. In the medications, I said ask about any blood thinner. Okay. Subconjunctival means that there is rupture of the blood vessels under the conjunctiva, which is the thin layer covering the white part of the eye. Or simply, above this white part of the eye, there are some blood vessels which runs between this white part and thin transparent layer which covers the red part. Those vessels are called subconjunctival vessels. When they rupture, they cause what you see we call subconjunctival hemorrhage, and it causes red eye. Why did I have it? Many times it can happen due to no reason. Mostly it can be due to hypertension, some other trauma which you did not have. However, mostly it happens for no reason. What are you going to do for me? It is self-limiting condition. However, your GP, we can monitor your blood pressure regularly to see if you have any blood pressure, which can be the cause to this. So it is self-limiting. Doctor, should I not take any medications? It is self-limiting. It will go away on its own. No need to take any medications. Doctor, should I worry about anything? Again, it is self-limiting. Usually, you will have some change in color, like it may turn like yellow or blue, like any bruise in the body. It will experience some change in the color till it fades away. Doctor, will I go blind? You will tell him, again, it is self-limiting condition. It will go away on its own. And more importantly, it does not affect the cornea, which is a central part of the eye. So, no chance of blindness at all. Very easy station, very quite straightforward, and very concise. And very concise. This is important. Yeah, he's so worried that he will go blind. He's so worried that he will go blind. Any patient will tell you, I'm so worried. Ask him why you're so worried. If he brings the blindness first, you will tell him that no chance of being blind because, yes, you reassure him, no chance of being blind because it does not involve the cornea and it usually fades away. Again, what should I do, doctor? It fades away. How does it go, doctor? It fades away. You will experience some change in the color. This station is about this only, reassurance only. So, and that's why I'm wondering why do they bring it as a separate station? But it's fine. You'll be lucky. Imagine one day which will be containing subconjunctival hemorrhage and food poisoning. Lucky people will get this. Okay. Let's move to some of the challenging stations from today. Actually, by the way, I added, no, don't say fundoscopy here, Dr. Yemin. Just say eye examination. Very enough. Inspection is very enough here. And when you say just I need to inspect or need to have a look at your eye, you'll find the examiner directly giving you the photo. Okay, which photo? You will see a photo of subconjunctival, like very red eye. This station I told you it's one of the easiest stations. So just pray that you get it. And it will finish maybe in 2 days. I know one friend actually who passed this station with 11 without reading it at all. He even said in the diagnosis that most probably the reason is due to some local hemorrhage in your eye. He did not even say subconjunctival, some local bleeding in your eye or hemorrhage in your eye. However, However, we need to confirm that we need to monitor blood pressure. He got 11 by saying that, but if you need to get 12, just say what I told you. Okay? What do you mean by vocalize the finding to the patient before diagnosis? Okay, you will look at the photo, Dr. Ofudli, and after looking at the photo, you will back to the patient and you will tell the patient, from my assessment, it seems that you're having condition we call subconjunctival hemorrhage. What is this? You will explain it and say in the end, and that's why you're having this redness in your eye. Okay? Simple, because it is supposed that you examine the eye itself. It's not like you look at the picture. No, it is actually that it's like that you examine the eye. So just say, from my assessment, it seems that you're having condition I call, or the cause of your redness or the eye is called like subconjunctival hemorrhage. Very simple. Do not vocalize the findings too much because it will take too much time of your management in most of the stations. Many scripts from some academies, they write the findings in details. Don't do this. It will take too much time from you. Just say that in case that, for example, the patient will tell you, what are you going to do for me? You will tell the patient, for example, we did many examinations. Most of them or all of them came back normal. However, we measured your blood pressure and it was a bit high. And that's why we need to keep you in the hospital. For example, I'm just giving you an example. So if you want to verbalize any findings to the patient, or if the patient asks you, what are you going to do for me? When the patient asks you, what are you going to do for me? Usually you start by doing the examination or the investigation. And after that, speak about the plan of management, which is number 1, admission or not, number 2, senior, number 3, symptomatic, number 4, definitive, and number 4, safety netting and warning sign. So what are you going to do for me? Number 1, we did and we will do. And number 3 is a treatment plan. Do not forget about this. Number 3 is a treatment plan. Number 1 is what we did and found positive. Do not mention everything. I mean, if you did many examinations or investigations and they are normal, no need to mention them back because this will waste your time. Of course, it's good to mention them, but it will waste your time. This is not what you are going to be marked upon. You're going to be marked upon the patient concern. Okay? Definitely with some interpersons. Okay. Let's move to other station as well. Okay. If the patient again, if the patient is not, or if the patient asks you, what are you going to do for me? What are you going to do for me? We usually start. Dr. Elvira, we said this at least 10 times before. Number 1, we are going to do some investigations. Which investigations? Okay. You will now say that the further investigation that you are going to do. Like, for example, you will tell him that we did many investigations, all of them came back normal. However, we measured your blood pressure for example, we did X-ray and the only finding was that you're having fluid around your lung. So we are going to do further investigations to find out the cause. Which investigations? He will say about all the investigations of the cough and shortness of breath. So how are you going to treat me, or what are you going to do next, doctor? We are going to, number 1, keep you in the hospital or not. Number 2, senior review or not. Number 3, symptomatic treatment. Number 4, definitive treatment. Number 5, safety netting and warning signs. Those are your treatment plan for any disease. Okay? Okay. Guys, please, if anyone is having something, please postpone it till the end. Because we still have at least 13 stations to cover. 13 stations to cover in 2 hours and a half. I can do this, but I'm not sure if you are going to follow this carefully or not. So I need to repeat too much so that everyone is concentrating and listening and following me. Because I know that some people are doing their job while listening to me, some other people are cooking, some other people are driving. So I may need to repeat something maybe once or twice. Okay. One more station before giving you a 5 minutes break. I'll give you this station instead of one of the stations of today. I will give you this station, which is the gout. Why? What's wrong, Dr. Ala? I did not see this emoji. Tell me what you mean. Dr. Ala. Dr. Ala. Cooking, yes. Isn't it true, Dr. Ala? Tell me honestly, isn't it true? It happens, right? Anyway, so the gout. Okay, the gout right now. This station is quite, guys, by the way, you just when you are studying this station, I need you to mark it as if you fail this station, this means that you do not deserve to pass PLAB 2. Seriously, the one who fails this station does not deserve to pass PLAB 2. This station, the
What's the session, buddy?
gout. I did not include it in yesterday's list, but I added it today. It is very easy, and you will get to know that you do not even need to study it. The pass mark to this station is 7 at least. When it first came, it pass mark, somebody showed it to me, and it was 6.2. Very easy stage. Why? Because you are FY2 in GP, and the patient is presented with leg swelling and pain. Sorry, 2 swelling and pain. Other information about the patient. The patient is 49 years old male. He's having hypertension. Has been treated with benzofluorothiazide. So now from the task itself, you know that it's gout, without even entering the cubicle. He has been treated with benzofluorothiazide 2.5 milligram recently. Before he used to take Ramipril. And he's having a hay fever as well. What is the relation? Nothing. He's just having hay fever. So talk to the patient and address his concern. Now you'll enter to the cubicle. You'll find the guy is having 2 pain and swelling. Elaborate it. Which side? Number 1. Number 2. When did it start? How did it start? Has it changed? Has it been continuous or comes and goes? Usually he will tell you there are episodes, but these days it comes more frequently. And it is redness and swelling. What is more important here? The more important thing is that when did it start, doctor? Or when did it start? He will tell you it started maybe 2 weeks ago or 3 weeks ago. Mind that he started the medication 2 weeks ago as well. So probably this gout is due to the medication. So now, what are you associating, or what are you associating symptoms? There is redness and swelling and pain. What could be the other things? Is there anything in any other joint? Okay, thank you, Dr. Maria. And welcome back, Dr. Mahdi. So, is there any problem with any other joint in the body? No. Or anywhere else? No. Is there any fever? No. Have you injured yourself recently? No. So now, these are the associating symptoms with this problem. What are your differential diagnoses? Maybe osteoarthritis or any trauma? Okay, so those are your differentials, osteoarthritis or any trauma. Okay, now move to the past medical history. Have ever happened before? He told you that it has come in episodes, but it never happened before. I mean, it did not happen before this time frame. What about the recent health? Have you had any fever or flu-like illness? Have you had any problem with your joint recently, or any problem with the movement? No. Any medical condition, he will tell you hypertension. He is taking benzofluorothiazide recently, and before that he used to take Ramipril. Recent change in medication. Okay, okay. Now move to the medications. He is taking as well cyclizine. Cyclizine is not important actually. So sorry, cetirizine chloride. It's for the allergy or for the hay fever. It's conclusive? No, it's not important. The important thing is the benzopyrrolizide diet, and it will be asked you in the management. Please mind that. By the way, the benzopyrrolizide here is 2.5. The lower dose is 1.25, which means that you can reduce the dose as well. Move to the family history. Sometimes there can be family history of gout. Ask him about the lifestyle. Very important. The gout is close associated to the lifestyle, to the smoking, to the diet, to the alcohol and physical activity. Alcohol can precipitate gout. Smoking can precipitate and worsen gout. Alcohol as well can diet can precipitate gout. How? Insufficient water intake and too much salt and meat can precipitate gout. It's also sometimes in the history it's important to ask him if he had any urinary stones before or not, or any renal or kidney stones before or not. Okay. Ask also about the job. Job is very important here because he's a taxi driver, so definitely this affected his driving. Why? But because he cannot pull the brake. And also ask about maybe ask also about some no, sorry, no travel history here. Just job is very enough. Now move to the examinations here. The examiner will show you a photo of red and swollen tooth. This is the only examination, or this is the only finding. Move to the investigations. You will do routine bloods and urine. Very enough. No need to imaging, just bloods and urine. Move to the disclosure. You're having condition we call gout. What? It is a condition which is the formation of many crystals and accumulation of the crystals in the joint space, which leads to accumulation of uric acid crystals, which is one of the body salts, and they accumulate in the joint space, which lead to the redness and the swelling that you are experiencing in your big toe. Why did I have it, doctor? Now you can speak about number 1, the blood pressure medication. Number 2, it runs in families as well. Number 3, also it's related to the dietary intake and the alcohol intake. What should I do? Right now you will prescribe for him some painkillers, anti-inflammatory painkillers like the ibuprofen. He will take them regularly till his pain subsides. When the pain subsides, you need to give him something called allopurinol. This is prophylactic, but he needs to take it when he is pain-free or when the episode is gone. So now he will take anti-inflammatory painkiller, but when the pain and swelling are reduced, he will take allopurinol. Very important. Okay? Okay. Will you do any investigations to me? Yes. You will do some investigations. We did the routine bloods and urine. We need to do urine culture as well to see if there is any bug. We need also to do CT scan, ultrasound on the joint to detect the crystals. We may need also to do joint aspiration. Take a sample from the fluid around the joint to detect the crystals in the sample. So here, ultrasound and joint aspiration are very important. Besides, of course, the routine blood tests, which are including UNEs, to see the amount of uric acid in the blood. Ultimately, if it's like for a long time, we can do X-ray to see if there's any damage to the joint, secondary to the accumulation of crystals. So X-ray is the last thing which happens only, or which can be ordered only after a long time. General advice you are going to give to the patient: we may need to follow you up, we may need to change or review your medication because it is the cause of this. And it's very important to know how to deal with these episodes if they ever come. Take your painkiller, and it's very important to apply some ice packs and raise your leg. Drink enough water. Wear loose shoes, not tight shoes, because it will worsen your redness and swelling. And also you can advise him, we said about the insufficient, you have to advise him with sufficient water intake, like the renal stones, sufficient water intake and alcohol and smoking to cut them down. So again, general advice, take medications whenever you're having this episode. Number 2, raise your leg. Number 3, apply ice packs. Number 4, smoking, alcohol, and diet. Number 5, speak about the water intake, which is very important. You can also advise him to use some vitamin C supplements or vitamin C containing food, maybe the lemon juice or orange juice. They listen, or they relieve the gout a little bit. Okay, this station is quite easy. No need to worry about it. What is the core of this station? Only the core is to know. The core is only to know about that it is one of the side effects of the medications that's given to him. So you will tell him that it's because of the medication. If he ever asks you, doctor, is a medication, why did you give me this medication if it caused me this? You'll simply tell him that I can see that you are concerned, but this is usually one of side effects, and this is one of the best medications for the hypertension. However, I'm sure you agree with me that every medication has its own side effects, and that's why we always warn our patients and advise our patients to come for follow-up. So it is one of the best medications, and every medication has side effects, so we always warn our patients to come for follow-up. Fair enough? Yes, fair enough. Dr. Zaid, no need to take sexual history here. If you want to take sexual history, it's fine, but I'm just giving you guys the most important points to focus on. I mean, you can take whatever you wish, but to save your time, I'm giving you the most important bullet points for each station. And after Dr. Manisha, what she said to me today, I need to focus more on how you guys are going to take history by myself. So from now on, I cannot offer you 1 minute, I cannot offer you 1 hour training in these days, but at least everyone, after the session, everyone will come. For example, I will pick up someone one day. You will be practicing some history taking with me, only for 2 minutes history taking. I will need to see how you're taking history from me. And one other management, how to see how you are going to manage this patient. This is the least thing that we can do right now. Then we start our practice after the course. After the course, everyone will practice 1 hour with me, 4 stations from different categories. This is what we can offer you to make sure that you know how to take history and how to approach each scenario in your own way. You can open the BNF. This is a good point, Dr. Kashi. You can open the BNF if you have time. It's good actually to open the BNF. But you know, everyone knows that one of side effects of the diet is gout. But if you open the BNF, it's absolutely fine. It's even better. It will take maybe half a minute from your time, but it's worth it. Even if you do not open the BNF, you still will score high in this station. But if you open the BNF, I'm sure you will score even higher. And we said it in the introduction session 3, that any side effect of any drug in the PLAB 2, you have to open the BNF. And you have to open the BNF if you suspect side effect from any drug. Okay, guys, I will give you right now 5 minutes break. We'll go back after the break. We'll continue our stations. We are still left with around. We only did confused. We only did like two and other 2. We did only 6 stations. We are left with at least 13 or 14, we are left with 14 stations. We need to do them in 2 hours. 2 hours and 15 minutes ultimately. Okay, so help me with that. We did right now 7 stations in 1 hour. We did 6 stations in 1 hour and 20 minutes. We need to like be a little bit faster. So I'll give you a few minutes break. Whoever needs to do anything, come back after 5 minutes. Let's move to everyone is attending right now. From now, we'll be a little bit quick, okay? We will start. Dr. Ahmad, can you tell us how? Yes, sure. Oh, this is a good question, Dr. Islam. You know what happens in the NHS? In the NHS, what happens is that, and even my friends, they tell me that they can excuse themselves and open the BNF in front of the patient. And even the patients themselves are having the culture that the doctor should open the BNF to be a safe doctor and prescribe the right thing. It's totally different from our countries. One surprise as well. One surprise is that you can check Google. You can check the NHS website to diagnose some conditions, but not in front of the patient, in the NHS. The only thing that can be done in front of the patient is that opening the BNF. BNF is your daily routine. You cannot be appointed in the NHS unless you know how to use the BNF. How to use the BNF? I will post to you right now something on the WhatsApp group, something interesting. Huh? I will post something interesting right now on the WhatsApp group, and please make sure that you check it. This is the latest version of the BNF, latest version from 2018. So please check it right now. Wait, just I'm trying to look for it. Wait, please. I'm just doing that before I forget, because after the course I may forget that. So I'm sorry for your time, because actually not you, it's not only you who ask about this, some other people as well ask about it. So I will send it to you right now, guys. I used to have the old version, but the recent version has been texted to me soon. So please, this is the next version, and it has been sent on the group right now. It's downloading, it's uploading, sorry. So check it. Yes, you have to bring your DNF with you all the time. No, it's yeah, you are speaking about Qatar, Dr. Zaid. I think so. Yes, definitely. They are committed to their BNFs. Okay, so let's move to one more station. The next station is one of the EC stations as well. It is the upper respiratory tract infection in a guy. Okay, in this station at least, you will have to, you are FY2 working in GP. The patient has been presented here 2 weeks ago because he was having some flu-like illness and he was diagnosed with upper respiratory tract infection. Some swab has been taken from him and it showed viral infection. So the swab has been taken and it showed viral infection. Now the guy has come, or the man has come, and he has got some concerns. Talk to the guy and address his concern. So simply, this guy was diagnosed with upper respiratory tract infection 2 weeks ago, and he was, by the way, he was given some symptomatic treatment like paracetamol and advised some rest. Now he came because he's having some concerns. Talk to the patient and address his concern. How to approach this station? Very easy station. Now, ask him for the reason of the visit. How can I help you? Doctor, I'm having these flu-like symptoms. They didn't go away. So I could see from my notes that you came here 2 weeks ago. May I know what were you told? No, may I know why did you come 2 weeks ago? I will tell you, doctor, I came because he was having some flu-like illness like cough and maybe some sneezing. And what were you told 2 weeks ago? They told me flu-like symptoms or something like cold throat infection. What have been given to you? He will tell you some symptomatic treatment like painkillers and advise some rest and some hot drinks. And how are you feeling right now? He will tell you, doctor, I'm still having these symptoms right now. Sorry, I'm sorry to tell you, he came 1 week ago, not 2 weeks ago. 1 week or even 5 days ago. I am sorry, I'm very sorry. It is 1 week or 5 days ago. Is the voice breaking, guys? Guys, is the voice breaking? Okay. Okay, so now ask for anyone who had any previous visit, always have this habit. Ask, may I know why did you come before? And ask about the symptoms or what was done and what was given and how are you feeling right now. What do you mean by I'm feeling right now, doctor? For example, tell me about your cough. Has it improved? Doctor, I'm still coughing. Has it changed from before? No, doctor, it's still the same. Did you develop any phlegm in the cough? No. Let's speak about your sneezing. Has it changed? No, doctor. Have you noticed any blocked nose? No, doctor. So when someone is not improving or telling you that they did not improve, you have to ask them about if they develop any of the complications or not, of the relevant condition. For example, if someone is like coming with upper respiratory tract infection which has not improved, now we need to ask about the current symptoms or the presenting symptoms of the upper respiratory tract, if they changed or not, and if they did not change, also ask about if he developed any complications or not. So you need to ask about the current status and about if he developed any complications or not. What could be the complications? Pneumonia and meningitis and otitis media. Pneumonia, meningitis, and otitis media. Those are the three things to rule out. And he's usually free. He's usually healthy. He does not have any problem right now except from the sneezing and the cough and the fluffy nose or runny nose. Move to the past medical history. Definitely, it happened to him before because any human being could have at least 2 or 3 flu episodes before. He was given some symptomatic treatment as well. But he has an episode of chest infection before for which he had received antibiotics. Doctor, that's why I need antibiotics. Sometimes he will start the station with you, doctor, I need antibiotics right now for my symptoms. What will you do? It's fine. I'm glad to receive you today, but before prescribing antibiotics for you, I need to ask you a few questions to be in a better position to help you. So now you can ask all the questions. He will keep interrupting you in the middle. I need antibiotics. I need antibiotics. You still need to ask some questions to see if he developed any complications or any other symptoms or not. So tell him simply, just to prescribe antibiotics, I need to have a complete assessment of your health. So please bear with me. Okay. He doesn't have any medical condition, no chest problem. He does not take any other medication. No family member of similar complaints, and no allergy. Lifestyle, smoking, light physical activity, and alcohol. You can ask about them. Ask also about any recent travel or any close contact to anyone else. Okay, in the examination, you will do ENT and chest examination. Ear, nose, and throat and chest examination. And the examination is quite normal. Investigations, the examiner will tell you, doctor, the investigation, the swab result is written in your task, which shows viral infection. Move to the patient, tell him that from what you told me, it seems that you're having a condition called upper respiratory tract infection. What is this? Infection in the upper respiratory tract, which is the ear and nose and throat. The upper respiratory tract, which is the nose and the throat. Most probably in your case due to viral infection as confirmed by the swab. Doctor, I need antibiotics. May I know why? Doctor, because I need the symptoms to be gone. He will simply assure him that this is self-limiting. It can barely take 2 weeks to resolve. Doctor, but I need antibiotics. May I know why? Doctor, I just it helped me recover faster last time. May I know what did you have in the last time? He will tell you that I was diagnosed with chest infection. So tell him that this is different because the chest infection is sort of strong infection and most probably bacterial infection, which needs antibiotics. However, in your case this time, it is number 1, viral infection. Number 2, doesn't need antibiotics because it's self-limiting. And number 3 as well, prescribing antibiotics unnecessarily may have some side effects and can develop resistance. So, doctor, when are you going to give me antibiotics? You will tell him that if you develop any of the complications, like what? Like pneumonia, and explain the symptoms of pneumonia, like meningitis, and explain symptoms of meningitis, or if your symptoms did not ease in these 2 weeks. So if his symptoms last for more than 2 weeks, or if he develop any of the complications, we are going to prescribe antibiotics. Okay. What are you going to do for measles, doctor? At this moment, you're going to give him some lifestyle advice. Like what? Any lifestyle advice that you guys do while having flu. Number one, enough rest. Having said that, try to be a little physically active because it improves your immunity and helps you get over. Number two, hot fluids, especially soup. Number three, avoid as much the tea and caffeine because they can worsen your headache. Number four, simple painkillers. Number five, simple cough supplements. Simple cough supplements or over-the-counter cough supplements. Okay, what else? Throat lozenges, like the strepsils or the strips that you chew when you are having a sore throat. What else? You can try some nasal drops for your blocked nose or your fluffy nose. You can also try taking warm baths for your fluffy nose as well. Okay, doctor. The voice is echoing. Will accept that and you can go home, definitely. But warning signs if you develop any shortness of breath or fever, if you develop any rash on your skin or shyness to the light, if you develop any discharge or swelling in your ear, come back to us. Which are the otitis media, meningitis, and pneumonia. Okay, so his concern is antibiotics, and you cannot give antibiotics for many reasons. Number one, it is viral infection. Number two, antibiotics have some side effects and develop resistance. Number three, it is self-limiting condition. Number four, we only give antibiotics in case of any complications develop or the immunocompromised patient. So this was clear, and this is the easy station that you can get as well from today. Let's move to some challenging stations. The fall and elder station. This is not ethical, Dr. Zaid, no. This is, okay, I think some academies may consider it ethical, but it's not that ethical because he's just here for some concerns. Like he just needs antibiotics, that's it. So you have to take his history and you have to assess him. I mean, it does not mind if you put him under the ethical compartment because it does not matter in the exam. But usually I discovered it in medicine, and my academy was found in the medicine and in other academies as well. But if Swami has included in the ethical, it's fine. He's just having some concern and you have to address. Okay, let's move to the fall in elder. Mind that the fall in elder changes every other day. You will end up having at least 5 or 6 scenarios for the fall in elder. Not so far. Not so far. Why? The fall in elder can be having some reason or many reasons. What are the reasons of fall in elder, doctor? I'm going to pick up someone. Dr. Manisha, tell me, what could be the reasons of fall in elder?
Hello. So it can be due to some non-medical causes like any kind of tripping or slipping because of wet floor or anything.
Okay, good. And what else?
Can be vision problems and
like what? No, explain. Tell me like what?
No, I didn't get you.
You said recent problems.
Yeah, no, I was saying about the vision problems. Any problem with eye?
Oh yes, vision problem. Yes. Vision. Yes, okay. What else?
Then any kind of cardiac problems, like any postural hypotension or
Good. Or heart
any,
racing, right?
yeah.
What else?
Then things like sick sinus syndrome.
Do not go further than this. Do not say sick sinus and such things. You are too deep.
Yeah.
What else?
Okay.
Let
Then
me,
any head
let me,
injury or things
okay,
like that.
perfect, perfect. What else? Continue, carry on.
Okay. What else?
Okay,
Any
let me,
hypotension, hypoglycemia, things like that.
okay, let me, you said almost everything. Let me point out the whole thing for you in an easy way.
Okay.
Okay, number one, for the elder, from before in any fall, you will start the fall from before and during and after. Before the fall, this old guy could be having hypoglycemia, which could lead him to fall, right? He could be having also vasovagal syncope if he saw anything strange or anything scary, right? What else? He could also be having some infection, which causes some confusion to him. He could be also having some constipation, which causes some confusion to him. During the fall, did he lose consciousness? No. What if he lost consciousness? This means that most probably this is due to head injury. So he lost consciousness because his head hit the ground. And after the fall, you will have also to ask about his memory, if he lost memory, if he was conscious after that, if he vomits after the fall or not, if he had any bleeding anywhere in his body or not after the fall, and if he developed any seizures or not. Very simple. This is the medical problems. What else before the fall? I told you hypoglycemia, I told you infection, I told you constipation, right? What else? Could be also arrhythmia. Arrhythmia can lead to a fall. You know, heart racing can cause sometimes fall, like drowsiness and fall. What else? Stroke. He can lose count and fall when he's having stroke, right? These are the most important things to be asked in the fall, before, during, and after. I will send you a scheme of the fall written by my hands, during and before and after. What are the important things to ask here? Always please ask him about social history. After finishing the medical history, ask about social history. Do assess the risk of the recurrence. What is the risk of the recurrence, guys? We need to see about his home condition. We need also to, like for example, any wet floor, any loose carpets. It's very important. The light in his home, is it enough or not? If the floors are slippery or not? Because those simple things can lead to a fall in the elder. Is he having any visual problem or not? Or if he having any ear problem or not, which can affect the balance. So, those are the things for an elder. Did I forget anything? The one who will tell me what did I forget, he will deserve £5, and I will give them the £5. This will be deducted from the course fees. I forgot something very important. Not really. You'll get it from social history as well. Blood pressure has been said, Dr. Maniba. Social history has been said. Whom do you live with? I need someone to tell me one important reason medications will be picked up from the medical conditions.
Is it non-accidental?
No.
Okay.
I forgot something which is characteristic for the elderly. Cerebellar problem, you are close, Dr. Lamy. You are close. Not really. Okay, SOL. SOL is a very important reason for the confusion, or the imbalance in the elder, space occupying lesion or brain tumor. So you'll be having many differential diagnoses in this patient to ask about. Okay, let's proceed to this patient. This guy, your FY2 work in A&E. The patient simply, the patient has been presented with a fall. Talk to the patient and address their concern. And manage the patient, please. Now you will enter to the patient. She's an old lady. Take from her history, like before the fall. How were you feeling before the fall? Did you have any dizziness? She will tell you, yes, doctor. Before the fall, I had dizziness. Dizziness before the fall points toward two things. Either problem with the blood pressure or problem with the ear. So, what do you mean by dizzy? She will tell you, doctor, I felt that I was sitting and then when I stood up, I felt dizzy after a while. So this means that she's having probably postural hypertension. When someone tells you dizziness, always ask, what do you mean by dizzy? Because this will point you toward the correct pathway. Okay, she was having dizziness before the fall. Did you have any sweating or any tremors in your body, which points toward hypoglycemia? Did you feel any heart racing, which points toward arrhythmia? Did you feel any weakness in your body, which points toward TIA or stroke? And did you have any did you have any blurry vision or problem with the movement? No, which points toward the SOL. All the findings are negative except for dizziness. During the fall, have you lost consciousness? Mostly, no. Have you had any fits or jerky movements? No. After the fall, how were you feeling? I was absolutely fine. Have you had any bleeding? Have you had any vomiting? Any loss of consciousness? Any memory problems? Any fits? Everything is negative. Now move to the past medical history. Any previous episodes? No. Recent health. Did you have any fever or flu-like symptoms recently? No. What about any constipation recently? No. Any morning headache recently? No. Why? Morning headache to rule out SOL. Infection, asked through fever or flu-like symptoms. Do you have any medical condition? Yes, I'm having high blood pressure. Since when? She will tell you, for example, since 20 years. How is it managed? Ramipril. Do you take it regularly? Yes. Have you experienced any recent change in the dose? Yes, doctor. I think my GP has doubled the dose to me. When was that? 3 days ago. So if you did not ask this question, you will miss the diagnosis. Ask about recent change in the dose. Recent change in the antihypertensive is one of the leading causes of postural hypertension. Okay, is your blood pressure well controlled? Yes. Do you have any symptoms like maybe headache or blurry vision? No. Any complications like swelling or heart racing in your body? No. Do you follow up with your GP? Yes. Do you have any other medical problem? Like what? Diabetes? No. Any brain problem? No. Do you take any medications? No. Ask about the family history. Family history of fall? No. Ask about the lifestyle as well. Smoking, diet, physical activity, and alcohol? Not that conclusive, but you can ask about them anyway. Ask about the home conditions. As a safe doctor, in anyone presented with fall, please ask them about the home conditions. How to ask about the home conditions, Dr. Zaid? Or social condition? How to ask about it? Dr. Zaid?
Hello.
Yeah.
Hello.
Tell me.
Okay, tell me, can you tell me more about your home condition?
Doctor, what do you want to know about my home condition?
Which floor do you live in?
I live usually my home. If you mean how many floors, I live in a two-story house.
Two-story house. And okay. And which floor do you live in? The first floor or ground floor?
No, I think I live upstairs.
Okay. And okay. The other question is how's the the floor at your home? Is it a slippery floor or not?
No,
The
doctor.
carpet.
No.
Okay. And what about the toilet? How can you manage in the toilet or?
Yeah, I don't have any problem with that.
And what about the social worker? Did they visit you, the social workers?
I do not have
Recently?
any social worker. I live with my daughter.
What about the light at your home?
It's enough.
At your
It's absolutely enough.
Okay, fine. And
okay, Dr. Zaid, I will tell you how to elaborate it. You will simply ask the patient, whom do you live with? I live alone, doctor, for example, or I live with my daughter, for example. Does she take care of you all the time? Not really, not all the time. So how do you manage? How are the things at home? What do you mean, doctor? For example, tell me, do you have enough lights at the home? Yes. What about any slippery floor? No. Any loose carpet or any wet carpet? No. So basically, the light and the carpets and the floors are very adequate in your home, right? Right. So 4 questions at all. Whom do you live with? And about the home condition, speak about the floor, speak about the carpet, and speak about the light. Okay, you asked a good question, which is the number of the floors. You can add it as well. How many floors are in your home? And which floor do you live in? This is very good, Dr. Zaid. But please do not spend much time on asking this because you're supposed to ask these questions in the end of your history taking. So you will be running out of time. You can also ask about any close one nearby in case of emergency. That's good as well. But she's telling you that she's living with her daughter. Okay, her daughter is sitting with her or staying with her except only for their work hours. Okay, now move to the examinations. In the examinations, you have to mention full body examinations. You have to say vitals including oxygen, blood pressure, including lying and standing blood pressure. Do not ever forget about the lying and standing blood pressure. Again, do not ever forget about lying and standing blood pressure. Do not ever forget about lying and standing blood pressure in any fall and elbow. Okay? Okay. Then you will do chest examination, heart examination, ear examination including otoscopy, eye examination including fundoscopy, okay, and tummy examination. And you can also do neurological examination. So full body examination. Move to the investigations. Which investigations? Protein bloods and urine and ECG. Why? Because these are the routine things that can cause a fall. One of them blood infection or hypoglycemia, the second urine infection, and the third ECG heart racing or arrhythmia. Those 3 things can cause infection. Move to the disclosure. By the way, the examiner will give you difference between lying and standing blood pressure. Dr. Ofodile, you think, can I say any difference between lying and standing blood pressure as postural hypertension? Any difference can be postural hypertension?
Yes.
You
when
think?
the systolic is greater than 20 millimeter mercury.
Perfect. When the difference between systolic is equal, hello? When the difference between the systolic pressure is equal or above 20 and the diastolic is equal or above 10. There you can say postural hypertension. Why I'm telling you this? Because there is a new scenario, they changed it, they fooled the people. The difference was only 10 grades. 10 grades between systolic and 5 grades in diastolic. There is also a third scenario, which they deceived all of the people. They give them the difference between the lying and sitting blood pressure they give them that the lying blood pressure is 100, for example, is 150 over 110. This is the lying, 150 over 110. And the standing, mind that, the standing, okay, sorry, the lying is 130 over 100. The lying is 130 over 100. And the standing is 150 over 110. Do you think this is called postural hypertension? Actually, the opposite. Why? Because when you stand up, the blood pressure is supposed to reduce, not the opposite. So the people have picked that up as postural hypertension. No, it's supposed to be less when you are standing, not higher when you are standing. Okay, so let's move to disclosure. We are going to tell the patient that your fall is because of a condition we call postural hypertension. It is a condition in which the blood pressure drops when you stand up suddenly after sitting down or after lying down. And in your case, it most probably happened due to the change in your medication. Why didn't they warn me about this? Well, actually, this is one of the best medications. However, one of its side effects, like any other blood pressure medication, is that it can cause a fall or postural hypertension. And unfortunately, it causes a fall in your case. But the good thing is that you come to us and we are going to manage you accordingly. What are you going to do to this patient? Number one, we need to keep her in the hospital. Anyone who's having a fall, it's unsafe to discharge them right now. So keep them in the hospital right now, especially if elder. We are going to review the medication, like reduce the dose of the medication with your senior. Number three, we're going to perform further investigations to see if you are having any infection, any problem like heart racing that we mentioned. And we are going also to perform CT scan. We are going to perform other X-rays. Why CT scan and X-rays and ultrasound? Because we need to exclude other injuries to different parts of the body due to fall. We're also going to examine your eye and ear. Okay, so routine bloods and urine and ECG and scans. Full body examination and full body investigation. After that, can I go home? If everything goes smooth, we can send you home definitely. But in any case of fall, always speak about the occupational therapist and physiotherapist as well. Why? Occupational therapist will explore her home condition to make sure that the home conditions are quite safe for her so that the fall will not recur again. And the physiotherapist is to improve her movement in case she is having any problem or struggling with the movement, or she is having problem with the balance. So do not forget to mention the occupational therapist, and do not forget to mention that we need to keep her in the hospital for a while. Okay, okay. These are the scenarios for elderly fall. What if it happens and there is no finding at all, or no reason for the fall elder? Can anyone guess what could be the fall? Dr. Muniba? Dr.
Weakness
Muniba?
in the body.
Yeah, perfect, Dr. Masi. So basically, if all the findings and the investigations came back normal, this means that the reason is due to the weakness in the muscles or the bones of the body. Say the muscles. So what we can do for the weakness? We are going to do Dexa Scan to check the bone density and the bone strength. We are also going to do some X-rays on different parts of the body to see if there's any other associated injury or not. And we can provide here with rehabilitation program. So if there is no other finding, we will offer Dexa Scan, and you will offer just different X-rays, and you will offer rehabilitation program. What is the rehabilitation program to her? To improve her muscle strength and to enable her to carry weight or strengthen her muscle under supervision of physiotherapist. What else will happen? Definitely will involve occupational therapist in any case of fall, especially in elderly, to explore the home conditions. No problem, Dr. Muniba, it's fine. So if every reason came back normal, you will suspect, and if the patient insists on knowing the reason, despite all normal findings, you will tell the patient that the reason is most probably due to your muscle weakness. There could be many reasons Many reasons, Dr. Zaid. One of them actually is vitamin deficiency. Good that it reminded me. Vitamin deficiency as well. We said everything. Routine bloods, urine, scans as well, and ECG, and eye examination and ear examination. If everything comes back normal, this means that the reason is the weakness in the body. Okay. Dr. Masih, she may ask you actually she may ask you this question. Doctor, which weakness? You will tell her that usually when we grow up, our muscles and our bones are not able to bear our weight like they used to do before. And this is quite normal with the age. However, we can offer you a variety of options, which is the rehabilitation program, the physiotherapist, and the occupational therapist as well. This program is to enable her to be able to bear weight on the series of exercises. This is good, Dr. Ella. The vitamin deficiency is rare in UK, especially the vitamin C, because the vitamin actually is related to the socio-economic level of the country. Vitamin C and vitamin B and these things are included in the food and the diet in UK as well. They are not low socio-economic. Guys, is anyone having problem with my voice? Hello, Dr. Mahdi, welcome today. Nice to meet you back. Guys, anyone have any problem with my mic? With my
Hello,
voice?
Dr. Hamid.
Yeah?
Hello, how are you?
I'm fine, Dr. Mahdi. Welcome back.
Yes, I have missed a lot, I believe.
No, don't worry, don't worry. No, I knew that you have been traveling and I recorded it for you.
Okay, thank you very much. Thank you very much.
Thank you.
Okay, I'm listening to you.
Your voice is
I'm
interrupting.
following you.
Your voice is interrupting, Dr. Mahdi. Guys, anyone has any problem with my voice from now? Just say yes or no, please, quickly. No problem, Mr. Mahdi. Take your time in the taxi and say hi to the taxi driver. So no one is having problem with my voice. Dr. Masih, I think the problem is from your side, not from my side. Dr. Mahdi himself, who is away and he is not working Wi-Fi, is saying no. So I think the problem is from your side. Yesterday, I admitted that the problem was from my side, but now your problem. Maybe it's a problem from your sound system sometimes. It happens anyway. So, by the way, I'm not away from the mic. I'm just sticking to the mic right now. Because in case there is any noise, I have to be close to the mic. The good thing is that our rate is very good today. So, we are still left with around 1, 2, 3, 4, 5, 6, 7, 8, 9, 12 stations. Can we finish them in 1 hour and a half? Yes, we can. We will be very quick right now. Excuse me if I'm going to speak a little bit faster. Okay, let's move to one interesting station, which is the head injury in elder. Before starting this station, I told you that if there is any guy who's having any fall, especially if elder guy, what are your differentials here in the fall in elder? I need someone to summarize the findings very quickly to me. Please be quick.
What was the question, brother?
No, I just need the symptoms, or sorry, the relevant medical conditions. What could be the reason of the fall in elderly? Again. Masih, tell me, what could be?
Postural hypertension.
Yeah. What else?
Problem, balance problem.
What else?
And it could be confusion, maybe UTI.
Yeah, exactly. Any infection can cause confusion and constipation as well.
Yeah, trauma.
Okay, what else?
muscle weakness, stroke.
Okay, that's great. And SOL.
SOL, yeah.
Okay. So you will need to ask all these questions? Yes, you will need to ask all these questions. By the way, starting from tomorrow, we will discuss ethics. So I consider that the boring part of the course will be done by today. I will send you the record of the remaining stations tonight as well, because yesterday I did not have connection. So from tomorrow, we'll discuss the ethics, and then after that, the counseling, after the counseling, the surgery, and after surgery, obs and gynae and psychiatry. Last day will be pediatrics, half of it, and the other half will be combined stations. And for the same man, I will send you the recordings of the same man. You will listen to them very well, and you will come and meet me 1 hour, 1 day later, maybe on 5th or 6th of May, 1 hour only or 1 hour and a half, and I need to practice some of them with you. This is for the same man. I will send you the recordings tonight as well on the group. Okay. So let's start with this station. Your FY2 work in A&E. The patient has come after having a fall. The patient actually is 68 years old. The male patient was presented with a fall. Talk to the patient and address his concern. By the way, the patient has hit his head during the fall. The ambulance brought him here, and he had some episodes of vomiting during the ambulance or during being in the ambulance. Okay? Okay. Mark this word. He has some episodes of vomiting during being in the ambulance. Some episodes of vomiting. Okay. So now it is very similar to the past station, but this guy has head injury, or when he fell to the ground, he injured his head and he went unconscious. So when someone is telling you, your question or your elaboration or approach will be before the fall, as we said, what you will ask about. Number 2, during the fall. During the fall, you will ask him, has you lost consciousness? He will tell you yes. Ask him for how long. He will tell you for a few minutes. Have you hit your head? He will tell you yes. Was there any bleeding? No. Okay. Did you have any jerky movements? Jerky movements are very important to be asked during the fall. After the fall, you'll ask him these questions like, did you have any vomiting? He will tell you, yes, I vomited like 3 or 4 times in the ambulance. This will be the reason we will keep him in the hospital actually. Why? Because actually, these 3 episodes of vomiting are the reason actually to admit him here in the hospital. So ask him after the fall, did he have any vomiting? He will say yes 3 times. Then ask about any loss of consciousness after the fall? No. Any bleeding after the fall? No. Any memory problem or difficulty recalling what happened? No. You know, this is called retrograde amnesia. Retrograde amnesia, which means that he is having memory loss regarding the fall, the event of the fall. Usually he does not have any problem with the memory. So did you notice, like, did you have any effects after the fall? No. Okay. So the only finding is that he had vomiting episodes after the fall and he lost consciousness during the fall due to head injury. So your history should be very similar to the past station in terms of past medical history and social history as well. Move to the examination portion. Very important. In the general physical examination, the patient told you that he hit his head or he hit his head to the floor. So stress on the general physical examination saying that I need to have a look at the head of the patient as well. The examiner will tell you, doctor, there is a bump on the forehead, like maybe 1 by 1 or 2 by 2 centimeters. So this means that there is head injury. Bruise. Okay, I need to do some investigations. Which investigations? Initials and ECG as well. Initial blood and urine and ECG. So all examinations, all body examinations and initial investigations only. You will tell him that the doctor was wrong with me. You will tell him that the reason of your loss of consciousness is due to the fall that you had, which has caused head injury. So this guy did not have any problem before the fall. He only lost consciousness only because he had a fall in which he had hit his head to the ground. So the reason of the loss of consciousness is due to head injury. So what are you going to do for me? We are going to examine all of you. Careful body examination and initial investigations. But after that, we need to keep you in the hospital. Why keep him in the hospital? Because he had some episodes of vomiting. So we need to make sure that there is no brain injury. But he does not want to stay in hospital. If any patient does not want to stay in hospital, doctor, let's pick up someone who is new. Okay, wait, let me pick up someone. Dr. Islam, tell me, what if someone tells you, doctor, I do not want to stay in hospital, I want to go home? What will you say? Islam.
Hello.
Yeah, I can hear you.
May I know why you don't want to be in the hospital?
Perfect. I will tell you, doctor, I just want to go home to maybe watch TV or something. Or maybe I want to go home to look after my granddaughter or my grandchildren.
Your health comes first.
Do not be too strict. Just say that I can understand that it can be quite frustrating to stay away from your beloved ones. But you know, we need to keep you here because you know you have some episodes of vomiting. So we need to make sure that everything is fine. Okay. What are you going to do for him in the hospital? You're going to do some scans to exclude other injuries, like CT scan and ultrasound. And you're going to perform CT scan on the head. Why CT scan? Because of the vomiting that he had. You will need to perform CT scan or you will need to consider CT scan to him. This is an indication of CT scan. More than one episode of vomiting after the fall is an indication for CT scan. He had 3 or 4 episodes of vomiting, which means that there could be a possibility of head injury or brain injury. The bruise as well. The bruise is one indication as well. Thank you, Dr. Munida. Okay, so what's next? We will keep him in the hospital, do this investigations and CT scan. What's next, doctor? After that, if everything goes smooth, we can send you home. But we need to make sure that your home conditions are quite safe. How? Occupational therapist. Why did he fail? There is no reason for the fall. This station actually is old station. Not all the pattern, no, it's old station. Here or these days, it comes with a twist. Which twist? The twist that I told you. There could be many, everything actually is fine. Everything is fine for him. Everything is fine for this guy except from only the fall. Okay? Okay. Actually, some people may explain it as vasovagal syncope or some sort like maybe he was taking alcohol and food in the restaurant before coming. So this could be one of the reasons, like maybe any allergy in any food that he took or anything like that. But there was no obvious reason to this fall in his case. But his loss of consciousness is due to the head injury, which is quite important. And by the way, that's why we are keeping him here in the hospital. We need first to find out or to treat his fall. Yes, he was coming up to restaurant. He was coming up to restaurant, like I told you, he was coming after alcohol and diet. He had a meal in the restaurant. But the important thing here, Dr. Elvira, I just remember right now, is that you need to first treat the presenting problem, which is the head injury and the vomiting. I mean, to treat the possibility of the brain injury due to the fall. And after that, later, you will try to dig to find out the reason of the fall. I hope you got my point. No problem, Dr. Bina, you told me before that. You told me beforehand that you need to go at 6:30. And it's my pleasure that you stayed beyond 6:30. So the thing is that here, you need to find the reason for the brain injury. And I told you, we need to do further investigations to find out the other reasons for the fall. That's why we'll tell the patient we need to run further investigations and we need to perform CT scan in your head to make sure that everything is fine with your head or your brain. Okay.
Brother.
Yeah.
What if he just had a single episode of vomiting?
Single episode of vomiting is not an indication for CT scan. So you will simply keep him here in the hospital without saying about CT scan.
Okay, so if he asks us for how long do I have to stay with them?
Just for a few hours. Usually you will keep him for 4 to 6 hours, but do not specify any period.
Okay, we just say for a few hours.
Yeah, for a few hours. Do not say any period or any time frame in PLAB 2. Unless in the patient of hypoglycemia, because he will ask you, doctor, for how long? Doctor, for how long? Because he is getting married soon, in 2 days, or in 1 day, sorry, tomorrow. His wedding party is tomorrow. But you know very well that hypoglycemia needs to be admitted for 24 hours at least. Okay? This is the only case. Other cases, you do not need to remember about the time frame at all. And if you even remember,
Yeah, go on, buddy, please.
If you even remember, do not mention it because it can be confusing sometimes. So if you are not aware about it or if you are not 100% sure, do not give wrong information.
Okay. Is there any need of mentioning any safety netting over here?
Yeah, I told you that when discharging him, we need to assure his safety by mentioning about the occupational therapist at home. And you can also warn him, like for example, he had an injury, right? You can warn him if you develop any further episodes of vomiting or any severe headache, come back to us.
All right. Thank you, buddy.
Okay. So let's move to the next station. Next station is a vestibular neuritis. It is an interesting station actually because the only finding here is upper respiratory tract infection 2 weeks ago and dizziness right now. So what do you think? Why don't I say that it's benign paroxysmal vertigo? Mind that the age here is not, I mean she is middle age, like 30 something years old. So what do you think, guys? Why do not I say benign paroxysmal vertigo? I need someone to answer me.
What was the question, buddy?
I mean, what is the difference between the vestibular neuritis and the benign paroxysmal vertigo? Duration.
It
That's
is
good.
considered like it is after a recent flu or recent upper respiratory tract infection.
Yeah, this is a clue here, that everything came only after upper respiratory tract infection. Always remember this. Okay, it came after upper respiratory tract infection. Okay, lasted for a few minutes. All right, and one important thing as well is that she does not have any history. And actually, when you mention, you have to mention Dix-Hallpike maneuver. Dix-Hallpike maneuver. I will write it. I will write it here. Yeah, so simply Dr. Yemi, because some people are confusing it. Some people from some academies are writing that it's benign paroxysmal vertigo. No, it can never be benign paroxysmal vertigo. So always mention in the examination section, Dix-Hallpike maneuver. Dix-Hallpike maneuver. Okay. Now, your task here says that you're F2 working in A&E, 28 years old female patient, has come with a sudden episode of dizziness after turning her head around. Talk to the patient and address her concern or address her condition and speak about the management plan. Okay. So simply this lady or this girl, sorry, had this episode of dizziness after turning her head around. They are trying to confuse you. Turning the head around will point you definitely toward benign paroxysmal vertigo, right? No. She will tell you, doctor, when you enter the cubicle, you will find she's telling you, doctor, I was at the supermarket and I turned my head and suddenly I felt dizzy. which next I fell down. So she felt dizzy, that's why she fell down. Okay? So now you have two complaints, Dr. Masih. The first complaint is dizziness, and second complaint is fall. Okay? How to elaborate them? Number one, dizziness. The first question should be Dr. Dr. Elvira, tell me what is the first question to ask in dizziness? Quickly. Dr. Elvira.
What do you mean by dizziness? Describe
Exactly. Like, okay, thank you so much. Doctor, I felt like the room was spinning around me. The room was spinning around me. You say that the room was spinning around me only, but they did not say that they changed of position, like they did not stand up. So it was only the room was spinning, which points towards something in the air. You can mute yourself, Dr. Elvira. Okay, so now she will give you the dizziness started 2 hours ago, and it has been continuous, okay, and it worsened by moving her head. There is another complaint as well. She told you that she felt dizzy and she had a fall. So elaborate the fall. But here you do not need to do complete elaboration of the fall. Why? Because you know very well that she has felt only dizzy before the fall. Okay? And her dizziness is due to the position, like changing the position of her head or neck, which means that it is probably something in the ear. So you'll get to know it from the past medical history. So you will ask about, let's speak about the fall. What, did you have anything abnormal or did you notice anything before the fall? Any symptoms? No. Only the dizziness. Apart from it, anything else? No. For example, any fever? No. Any weakness on one side of the body? No. During the fall, did you lose consciousness? No. Did you have any jerky movements with or fits all over your body? No. After the fall, did you vomit? Did you notice any weakness on one side? And did you have any injury? No. So you will elaborate the fall and you will elaborate the disease. Dr. Muniba also say that she will have a bucket of her hand. Why? Because she can be having nausea and vomiting as well. So after elaborating the fall and disease, ask her, do you have anything else? Yes, doctor. I had some episodes of vomiting. Sorry, no, doctor. I don't have anything, but I feel that I'm going to vomit. So basically, she's feeling nauseated. So she's having nausea as well. Okay, differentials here. Differentials are maybe upper respiratory tract infection, maybe benign paroxysmal vertigo, maybe otitis media as well, maybe stroke. Why stroke? Sudden dizziness which led to a fall. Could be postural hypotension. Like that, differential diagnosis definitely of the fall in elder, but she's young, so do not assume SOL. So simply it's something from the ear here. And how to know about that? Let's speak about that. Ask her any further questions. Did you feel any problem in your ear? Like what, doctor? Like, did you have, like for example, did you have any fullness in your ear? No, doctor. Any discharge from your ear? No, doctor. Let's speak about the PMH. She didn't have any similar episodes in the past, and her recent health points toward upper respiratory tract infection 2 weeks ago. Upper respiratory tract infection 2 weeks ago. Okay, okay. Did you have anything else apart from that? Like what, doctor? Did you have any fever? No. Any rash? No. Any urinary symptoms or urinary problems? No. Why? I'm ruling out the infection. So again, the DDs should be number 1, ear infection. Number 2, general infection like meningitis or whatever. Number 3, stroke. Number 4, ear problem. Okay. Now, you can also ask her about heart racing as well. Did you have any heart racing? No. Do you have any medical condition? Do you have any high blood sugar? No. Any high blood pressure? No. Family history? Not that important. Lifestyle, actually, you can ask me about smoking and alcohol only is very enough. But there is one thing to remember, Doctor Who? Dr. Yasmin, you know, this female patient, I need to ask her some questions. What are these questions? Dr. Yasmin.
In which case, Dr. Ahmad, you are asking? Like this one, vestibular neuritis?
Yeah, I mean, she's female patient. Which
Yes.
questions are important for any female patient?
4 P's.
Exactly.
Yeah.
Very good. Why? Why I'm asking the 4 P's here and never forget the 4 P's? Why?
Because here you can think about like if patient is young, so like heavy bleeding could give tiredness and for anemia symptoms, and moreover pregnancy.
Ectopic pregnancy. That's what I wanted to hear.
Pregnancy,
Yes.
ectopic, yeah.
This is one of the reasons of dizziness in the young age. Sudden
Yeah.
dizziness in young age. Though it is a little bit not strong or not like high possibility, but still I have to ask about it.
Mhm.
So, ear differentials here again, ear infection, could be infection, general infection, could be stroke, could be heart racing, and could be as well ectopic pregnancy, which I'm going to ask through the 4 Ps. She will tell you that the last menstrual period was 2 weeks ago. Do I need to proceed further? No. Okay, now ask about the examinations. In the examinations, you will do again all the examinations of the 4th, like the one before. But do not forget to mention the Dix-Hall-Pike maneuver. Okay? Okay. I need to do some investigations. Which investigations? I need to do routine bloods and urine and ECG. Again, like any 4th. What is going on, doctor? You're having a condition we call vestibular neuritis. What is vestibular neuritis? From its name, it is inflammation in the nerve which transmits the signal between the ear and the brain, which is called vestibulocochlear nerve. So it is an infection or inflammation in the nerve which sends signal from the inner ear to the brain. And this nerve is responsible for balance and coordination. That's why you have this cold. Why did I have it? Due to the upper respiratory tract infection, which traveled to the inner ear and infected as well. What are you going to do for me? We're going to do, number 1, further investigations. The routine investigations that we mentioned about, routine bloods and urine and ECG. If someone is confused about what to do when the patient asks me what you're going to do for me, always start with the investigations. We are going to do further investigations to you. We're going to do bloods and urines and ECG. Start with the initial investigations, and you can then move to the further investigations. And so, doctor, how are you going to treat me? We're going to keep you in the hospital here or in the A&E here, okay? Why, doctor? Why you are going to keep me? Because you had a fall, and we need to keep a closer look at you to make sure that everything is all right. We need also to give you some medications. Which medications we are going to give to this patient? We are going to give her some anti-sickness medication. You know, like we call the cyclizine. We're going to give this patient some anti-sickness medication. Why? Because this anti-sickness medication also acts against the dizziness. So we're going to give her some anti-sickness medication for 3 days. Yes, beta cert. Okay, so doctor, is it serious? Okay, when the patient asks you, is it serious? You always ask me, I know why you think so. Then you will tell her that it's usually a common condition and it's usually due to the upper respiratory tract infection or the flu-like symptoms that you have, and it usually resolves in its own within few weeks. Okay? However, sometimes there can be some unsteadiness for 2 months more. So usually it resolves in its own. When can I go home? Actually, you told her that you're going to keep her, right? You can send her home only which is able to tolerate food and fluids because this patient is having nausea, bad nausea. So if you give her any food or fluid and you send her home, she may have vomiting and even aspiration pneumonia, especially while sleeping. So you need to make sure that she's able to take any food and fluid before going back home. And one important thing, don't you need to mention the occupational therapy here? Yes, you have to, because this patient is liable to have a fall again. But she's young age, so it's better to keep her here in the hospital and manage her accordingly, and before sending her home, giving her some advice. Okay? Okay. What will the advice be? The advice will be that actually the symptoms will settle down. But if your symptoms did not settle down, we can refer you to specialist, or your GP will refer you to specialist. Why? Because if the symptoms did not settle down, this means that there is a possibility of something else in the inner ear. So we need to do CT or MRI to the inner ear. Okay? So simply, if the symptoms did not go away within 1 week or within few weeks, we need to send you for further investigations by specialists. Someone who's having dizziness as well, we need to warn them about the alcohol and operating heavy machinery. Please do not operate heavy machinery or do not drink much alcohol. And do not drive. And one important thing, you ask her about her profession. Why I am asking about her profession? Because actually, if her profession involves driving, or if her profession involves going to heights, or if her profession operates heavy machinery, it's very risky to her. So advise her to abstain from that at least till she gets better, and inform her employer that she's having this episode, because this episode may come back at any time. Okay? Okay. Before sending her home, so again, I give her general advice about her operating heavy machinery and about her symptoms, if they do not settle within 2 weeks. Before sending her home, we need to make sure that she is quite safe at home. So we need to make sure that her distance is solved. And the second thing is that we need to make sure that there's someone to take care of her. Okay, okay. So we need to, anyone is having dizziness or any fall in PLAB 2, always make sure that you are having someone to look after her at home. Okay. Right now, let's move to another station, which is the viral encephalitis. Viral encephalitis is one of the most, I think it's the easiest station because you know the diagnosis whenever you enter the critical. But you will waste 1 minute in the start of the station. Why? I will tell you why. You will waste 1 minute actually because the examiner will give you a paper full of examinations and investigations. However, you will pick up the task or you will pick up everything the moment you enter the critical. So it's easy way. Okay, let's see. Wait for 1 minute, guys. Hello, sorry for the interruption. So, by the way, this session guide will last at least 1 hour and 15 minutes more. This is the last day, and we should cover the remaining stations of the medicine. Medicine is the biggest compartment. It's 60 or 60 something stations, and we've managed to finish them in 3 days. Okay, the remaining stations from yesterday will be sent and recording, but today's stations must be finished. At least we can be left with only 2 of them to be discussed tomorrow, but not more than this. And for today, we are remaining with at least 1, 2, 3, 4, 5, 6, 7, 8, 9 stations. We are remaining with 9 stations. We need to finish them in 1 hour or slightly more than 1 hour. So we need to be a little bit quicker. We will finish each station in maybe ultimately 10 minutes. So let's be quick. Okay. Let's speak about the viral encephalitis. You will enter the cubicle. You'll find this man is quite worried about his son. Excuse him, greet yourself to him, and the examiner will tell you, doctor, you have your findings in the cubicle or in the table beside you. Confirm your findings. Okay? Okay. So, whenever you're having something, always excuse yourself from the patient. If you do not excuse yourself from the patient, I am sorry, I may consider this is rude. Okay, so now you will move to the patient. Actually, you will, sorry, excuse me for a minute, guys, I'm sorry. Okay, so you will enter the cubicle. The task here, by the way, will tell you that your FY2 in A&E, and the patient is middle-aged boy. He's like 21 or 22 years old. He has been watching TV, and suddenly his father noticed that he had strange, unfamiliar behavior. He started uttering some strange words, and he had fits after that, jerky movements. He came to the A&E, and he had only 1 episode of vomiting in the A&E. And manage the. When you enter the cubicle, you'll find the report of the patient beside you on the table. So talk to the father and address his concern and speak about the management plan to the patient, about the management plan of the patient. When you enter the cubicle, you will greet yourself to the father and reassure him, and then excuse yourself from him and pick up the paper on the table. In this paper, there were written at least like maybe 12 or 13 findings. All of them are normal. What are the findings, or what are the positive findings? The temperature is 38, so there is a fever, and the lumbar puncture shows lymphocytosis only. So lymphocytosis plus fever, which points toward viral infection. Again, lymphocytosis and fever points toward viral infection. Other examinations are normal. Like what? Like no Brzezinski sign, no Kernig sign, no neck stiffness, no rash, no photophobia, and the GCS is normal. This means that meningitis has been ruled out. Okay. So, you will ask the father about the fit, and he will tell you the whole story that I told you, and that's written in the task. Ask him, this is before the fit. In any fit, elaboration of the fit is like the elaboration of the fall. Before, during, and after. Before the fit, the father will tell you the whole story. Like what? Like, he was having change in the personality, like uttering strange words. He was like unstable. He was like drowsy. He was lethargic. His behavior was strange. He will tell you the whole story. During the fit, it is your mission. You will ask the father about how long it lasted, 2 minutes. And he had jerky movements, right? He will tell you, yes, doctor, he had. So were they all over the body or in special parts of the body? He will tell you that they were all over the body. When someone is having fit, we need to ask about if there is any loss of consciousness during the fit, if there is up rolling of the eye, or if there is biting of the tongue, or if he wet himself. Those are three questions, like biting of the tongue, uprolling of the eye, and wetting himself. After the fit, again, did he feel drowsy? Did he hit himself anywhere? Did he feel any weak? Like exactly the fourth. So the specific question here is during the fit, asked about any uprolling the eye, biting of the tongue, and wetting himself. Those are the three specific questions which happen during the fit. Otherwise, it's definitely like the fourth elaboration. Past medical history is inconclusive for anything, only it shows that he was having upper respiratory tract infection 2 weeks ago. Okay, you can also ask about any cancer, but usually this guy is not having any cancer. Like maybe any lumps or bump in the body? No. Okay. By the way, here no need to take too much history because the report that you took in the beginning is quite conclusive for everything. Okay, now you can also ask from the question. You can ask about lifestyle, and you can ask also about recreational drug abuse as well, because this is one reason of the fits, sudden fits in the middle age. Okay, one important thing actually to ask here is that in the examinations. Now move to the examination actually. What you will find in the examination, nothing in the examination. But you will do everything in the examination as well. Okay, like full body examination, as a whole exactly. But the most important is the neurological examination. Everything is normal. What's going on? You're having condition or your son is having condition we call viral encephalitis. What is this? Infection of the brain due to viral infection, in which the brain becomes inflamed and swollen. Is it serious? Yes, it can be serious, but your son is in good hands, and the good thing is that we are going to start the treatment, or we started the treatment as soon as possible. Okay, what will you do to my son? Now, what you will do, you can say the positive thing that we found. You will tell him, for example, we have examined him, he was drowsy and confused, and we also took a sample from the fluid around his spine, and we noticed abnormal high cells, which are the lymphocytes, and his temperature was on the higher side as well. So we need to do further investigations to him. Which investigations that you can do to him here? Some blood culture. The examiner will tell you, doctor, the blood culture result is awaiting. So we can do urinary culture, and we can also order EEG. Why EEG? In any fit here, you can order EEG specially. Why? Yes, it is the first time fit, but you can still order EEG here. It's no problem. This is sudden fit. You can order EEG here. Okay? Okay. So here your further investigations, which is not even important because viral encephalitis is most probably clinical diagnosis. Okay? So you can always say further investigations are urinary culture and EEG. Doctor, is he going to die? Don't worry, your son is in good hands. We will start his treatment as soon as possible. This condition can be serious sometimes and fatal, but the good thing is that he came to us in the right time. Why did he have this problem? If he asks you, you can tell him that this is due to the viral infection that he had 2 weeks ago, which travels to his brain. Also, one other reason is that the autoimmune theory. Sometimes our immunity, due to the infection, fight against our own tissue. So here, in this case, it fought against the brain tissue, which caused inflammation and swelling. So, two reasons, autoimmune theory or traveling of the infection. Are you going to give any medication? Oh my God, this is too long. So here comes the investigation, or sorry, here comes the management plan. Number one, you're going to keep him in the hospital, specifically in the ICU. This is number one. Number two, you're going to inform your senior. Number three, you're going to give him antiviral medications like IV acyclovir, add a drip in his blood vessel. Course of 2 weeks. Sorry, course of 3 weeks or 2 weeks. So acyclovir is the definitive treatment here. You can start with it, or you can simply tell him we are going to give him something for his fever, symptomatic, We are also going to give him something for the fits, another symptomatic. We are also going to give him antiviral medication we call acyclovir as a drip in his blood vessel. One important thing, we need to monitor his vitals. Anyone who is having fits, you need to monitor his A and B definitely. And you may need to give him steroids. Definitely remember the meningitis case. We said steroids are very important to prevent further brain inflammation. Okay? Okay. This is the treatment. How will you say it? Never say it in one go. Say 2 sentences and take pause. 2 sentences and take pause. And same in the DKA station. 2 sentences and pause. If he asks you, are you going to give him antibiotics? You will say that no need to give antibiotics. Why? Because this is viral infection. It's not antibiotic. We're going to give him antiviral, which will work against the virus. Is he going to be fine? Okay. Actually, when the treatment starts earlier, the chance of recovery is high. And most of the people will make full recovery. However, sometimes there can be left with some complications, or sometimes it can take them longer to recover. Which complications? Okay, we will now speak about, guys, any neurological complaint. The complications are, number 1, long-standing fits. Number 2, change in personality. Number 3, problem with the movement. Number 4, problem with sensation. Number 5, difficulty understanding. Number 6, speech problem. These things, always remember them every time. Again, problem with movement, problem with sensation, problem with speech, problem with understanding, problem in his behavior, and long-standing fits. The complaints to any neurological problem. Always remember them. And if this happens, we can provide him some treatment options or some plans. Like what? Number 1, again, neuropsychologist. Neuropsychologist will deal with that in terms of his follow-up, and we will offer him some rehabilitation program. The occupational therapist will explore his life and his social skills that we're lacking due to this problem, or we're lacking as a complication to this problem. Number 3, speech therapist to deal with his speech problem. Number 4, physiotherapist to deal with his movement problem. For how long will he stay in hospital? Till he finishes the course of the antiviral medication, 3 weeks. This station is challenging, but it's very easy. So to sum it up, no need to give antibiotics. We will keep him here in the hospital to give IV acyclovir. The prognosis is good when the treatment is started earlier. However, there could be further complications. Like what? As any neurological problem. Any neurological problem. Like what? Again, like number 1, speech problem, difficulty understanding, problem walking, problem behavior, problem in the behavior, and difficulty understanding. And as well, long-standing fits that he already experienced. How to tackle them? Neuropsychologist, speech and occupational therapist, and physiotherapist. Please remember these things in any neurological complaint. How long will you keep him in the hospital? 3 weeks or 2 weeks. Give me 1 minute. Sorry, excuse me. Hello? I'm sorry, guys. So, can you hear me? Can you hear me clearly now? Okay. So, let's move to the next station for today. So let me bring the paper with. Hello, sorry for the delay. So, let's move to the next station. First of all, the viral encephalitis station is a very easy station. You just only remember that this guy is having viral infection, which needs IV acyclovir, and it is long-standing process, which needs patience. So he can stay ill for a little bit more. Okay, let's discuss one of the challenging stations, which is the bloody diarrhea. After this bloody diarrhea, we will be having to discuss at least 1, 2, 3, 4, 5, 6, 7, 8 stations. So we will discuss 8 stations after this, which means that we need to be fast. Each station alternately in 10 minutes. Okay? Okay. In the bloody diarrhea station, you are FY2, working in GP. Okay? And the patient is presented with some episodes of diarrhea. Bloody diarrhea. They will tell you that she is having bloody diarrhea, and in the recent scenario, they will tell you that she is having bowel problem. Bowel problem. Okay, Dr. Elvira, no problem. No problem. Just will be remaining with some stations. It can be. I will record. I will record the last part for you. No problem. Just a guys reminder. Today is the longest session, but the next days will never stay that long, because the medicine stations are 60 beyond, and all of them are containing details. Okay, that's why I have to be a little bit longer. I mean, I take longer session today. Okay, so now let's move to the bloody diarrhea station. In the bloody diarrhea station, she is maybe like 40-something years old female patient. She is presented with episodes of bloody diarrhea. Okay, what are the differentials for the bloody diarrhea? Or what are the differentials generally for diarrhea in this age? She is, I'm sorry, she is 52 years old, not 40. She is 52 or 55 years old. Okay, okay. So she will tell you that she is having this diarrhea. Elaborate the diarrhea very good, like we learn how to elaborate it. When you are asking her about the diarrhea, you will ask her about any discharge, any blood in the diarrhea. She'll tell you, yes, doctor, I had some episodes. How many episodes? She can tell you twice. Ask about the amount and the color of the blood. It is bright red blood, handful, bright red blood, okay? And, or speaks of bright red blood. And you can ask about blood clots, no blood clots. Okay? And it was mixed with the stool. So again, amount, color, blood clots, and mixed with the stool or not. Amount, color, blood clots, mixed with the stool or not. The associating symptoms. What are the associating symptoms to diarrhea? We agreed. Fever, any episodes of constipation in between, When someone is having long-standing diarrhea, what is the most important question, Dr. Masih?
I'm thirsty. Do you feel thirsty?
Yeah, exactly. Dehydration, right? Very good. So long-standing diarrhea, we need to ask about what? We need to ask about if you feel thirsty or not. Okay? Okay. Clear so far, I hope so. Okay, so let's move to the next portion. We asked about fever, any episodes of constipation, about dehydration. Everything is negative. You can also ask about abdominal pain. Those are the associating symptoms. What are your differentials? The most important differentials are cancer and inflammatory bowel disease. Cancer and inflammatory bowel disease. You will ask about any previous episodes. This is for the inflammatory bowel disease. And for the cancer, you will ask about any weight loss, any loss of appetite. It's very important to rule out these two things. Other differentials will include maybe any thyroid problem, like do you feel hot when the other people feel okay with the weather? You can also ask about the piles. Do you have any mass coming out from your back passage? So again, differentials, most important are cancer and inflammatory bowel disease. How to ask about IBD, any previous episodes or any alternating episodes of constipation and diarrhea. This is very important. So now we finish the differential diagnosis. Move to the medical conditions. She does not have any medical condition, and in the medication, she does not receive any blood thinner. Sometimes she can give you a history of hypertension, elaborate the hypertension as well, but it is irrelevant anyway. Okay, okay. Now ask her about any similar symptoms in any family member, any diarrhea or any infection. We can also ask about similar symptoms in any family member or any family history of similar problem. Always ask about this. Lifestyle is very important here. Ask about the lifestyle. Okay. And very important question to ask in the lifestyle is that do you eat red meat? Why? Because the red meat, the prolonged use of red meat is one risk of colon cancer. So always ask this question. I mean, ask all the lifestyle questions, but focus more on the diet and smoking as well. Okay, okay. Examinations, you will do the most important examinations are tummy and the back passage. Okay, all examinations are normal. So this patient so far is having episodes of bloody diarrhea. All the age episodes with bloody diarrhea. What do you think? The most common possibility is colon cancer. But we will tell the patient that it seems that you are having a problem in your bowel. Which problem? We are going to do further investigations to confirm. Routine bloods, including blood culture as well, and antibody tests. Why antibody? Because I need to rule out IBD. Do not ever forget the antibody tests here. Okay? And we need also to do some scans like ultrasound and CT scan to your abdomen. And we need to take stool sample as well. So routine bloods and urine, number one. Number two, of course, including blood culture and antibodies. Number two, scans. Number three, stool sample. Why stool sample? To detect if there's any infection. If they come back normal, we may need to refer you to specialist for one test. What is the test here that you need to refer to specialist? We call it colonoscopy. This is the core of this station, because here comes the concern. Why colonoscopy, doctor, or what's colonoscopy? Camera test from your back passage. Why are you going to do this for me? Because we need to find the possible cause of your diarrhea. Doctor, is it cancer? May I know why you think so? Because doctor, you are going to give me this colonoscopy. Well, actually, this is we need to do it to find out the cause. However, cancer could be one of the possibilities. Actually, cancer here is one of the possibilities. Okay, okay. So sometimes you'll have some concern regarding that. Which concern you will be having regarding the colonoscopy? It's painful. We will numb the area. Doctor, but I do not want to have it. Okay, now you will scare her. Having bloody diarrhea could be having many reasons. Most of them are benign, however, there can be some serious reasons. So we need to do this colonoscopy to find out the exact reason to treat you properly. So again, we will tell her that this colonoscopy is essential in terms of determining the diagnosis, to find out the exact cause, because having long-standing diarrhea, especially with blood, can be having some serious problems. When you tell her about this, she will be convinced. One thing, if she asks you what will you see in the colonoscopy, you simply will visualize the inside of her bowl, and you can take a sample to detect it under microscopy. For the colonoscopy, if anyone asks you about pain, you will say you will numb the area. However, it might feel a bit uncomfortable, but this will be temporary. If the patient asks you, is it essential? Yes, it is essential to confirm the diagnosis. Okay, what will you see? You will see the inside of the bowl and take some sample as well. Okay, this is the station of the bloody diarrhea, so you never know the diagnosis here. Usually, I like these stations in which you do not know the diagnosis. Why? Because the history will be long and your management will be 1 or 2 minutes ultimately. But please mark the colonoscopy as the core of this station. If you ask about everything and manage everything in this station without telling about the colonoscopy, you will end up getting 5, which happened to one of my friends. He said everything. He even got 3 in the interpersonals, but 2 in data gathering, and he did not speak about the colonoscopy, so he got 0 in the management. So please speak about the colonoscopy and make sure that you address the patient concern regarding the colonoscopy. And in some cases, the simulator can be helpful, and they can tell you, doctor, I have heard about the camera test, which can be introduced through the back passage. So please make sure that you speak about the colonoscopy. At least reach it and offer it. Okay, this is for the bloody diarrhea station. What's next? Let's speak about one of the EC stations as well, which is the tinea corporis, or the ringworm infection. After the tinea corporis, we'll discuss the Guillain-Barré and Gilbert and hepatitis.
Which one are we discussing?
Huh?
Which one are we going to discuss now?
Right now we're going to discuss the tinea corporis, or the ringworm infection. This station is called in some academies as skin lesion, or skin rash, skin rash. The red rash on the forearm. Red rash in the forearm, like normal rash. This is the only station in PLAB 2 in which you can find a rash on the skin. Okay? The easiest station that you can ever get from today's stations. And you pray that you get it, but with only one silly concern. Why I say silly? Because it's silly concern. We will see right now. Okay, let's start. Your FY2 working GP. Okay, the patient is female patient and she's presented with skin problem. Talk to the patient and address her concern. Address his concern. He is a male patient. Especially when the patient is worried. Okay? Sometimes the task will tell you only he's having some problem. So can you imagine the whole task saying that the patient is having a problem? And when you enter, you will know everything. This is the new trend, by the way. This is how they react these days. Only small problem. I can see that around some people are leaving without giving any reason or any excuses. I know that today's session is very boring, but it's not a reason, or it's not it's not an excuse to leave in silence. You have always to inform that you are going to leave. Okay. So when you enter, you'll find that the guy is, yes, that's true, fungal infection, Dr. Elvira. So his guy is very worried and he's having a rash on his forearm. When someone is having a rash, you will ask about number one, where is the rash? Number two, when did it start? How did it start? Remember when and how and size and shape and color and bleeding or ulceration and itching as well. Size, shape, color, bleeding and itching. And any change in it in terms of size or shape or color. These are the most important questions for any skin lesion. Usually he will give you this skin lesion which is rash and it has been there for the past 2 weeks and it's increasing in size and it is red in color and it's itching as well. It's not painful. Okay, no bleeding, no discharge, no anything else. So only itchy red rash which increase in size. So definitely, characteristic thing for any fungal infection is that it increases in size by time, in short time. Rash which increase in size in short time is usually fungal infection. Okay. Sometimes he can show you the picture of the skin lesion from the beginning of the stage. If this ever happens, guys, this means that you can say the diagnosis very quickly. If this ever happens, this means that you should not ask like many questions about the shape and the color because it's shown in the photo. So if the photo shows you the skin lesion, please do not ask much history about the skin lesion because it's quite obvious before your eyes. Move to the associating symptoms. For any associating symptoms, you'll ask him any other rash anywhere in the body. Usually this happened only 2 weeks ago. So no need to ask about maybe, no need to ask about any other things like, for example, no need to go deep. Okay, Dr. Elvira, no problem. No need to ask about further details. But Dr. Maria, what happened? No, I think this problem happened to you yesterday as well. This problem happened to you yesterday because you could not join back. I think it's from your side. Because all the members here are joining permanently. Please, whenever you leave the group or whenever you have anything, just text me in private. Text me in private here. Do not go to WhatsApp because I'm not on WhatsApp at the moment. I'm in session. Okay? Okay. So, what are your differentials here? You usually ask about cancer. I mean, you can ask about cancer, but it's not that essential. But it's better because you will not have any other differential diagnosis. So better to ask about cancer here symptoms. What are the cancer symptoms? Have you lost any weight? Do you feel tired? Do you have any shortness of breath? Like the usual cancer symptoms. Okay? Do not ever forget to ask about these symptoms, please. Cancer symptoms. Okay? Okay. Also, you can ask in the past medical history if he is immunocompromised or not. Like, do you have any high blood sugar? Any skin problem? Why? Because these things can be risk factors for developing red skin problem as well. So, high blood sugar and other skin problems. And family history is important because if there is family history or history of same problem in close contact, it can be contagious. So, important things here. Number one, rule out cancer. Number two, ask about any immunocompromising disease. Number three, ask about family history or close contact. Personal history, smoking is very enough. Here comes the problem. In any skin lesion, you need to ask social history very carefully. Why? Usually he got this infection from someone who's close contact to him. Whom you live with? He lives at his home, like with his wife. What do you work? Why the work is important? Because in some work or in some jobs, they are gathered in some hostels. So the sharing of the towels and the sharing of the bed linings are very common. So you need to ask about the job. He's IT engineer. So job number one. Number two, do you have any cats or pets at home? This is the core of this station. He is having a cat. And this cat is having similar problem. Okay? Okay. Usually this cat is having the Same problem. Okay, what if the cat is not having? I will tell you what to tell. Okay, now you will do the examinations. You'll have to look at the lesion, which is already the photo was given to you in the beginning of the station. Do some investigations. Which investigations? Just routine blood to see if there's any anemia or not. If the patient, as now who disclosed the diagnosis, you're having a condition called ringworm infection or fungal infection. What is this, doctor? Fungal infection is a sort of skin infection which happens or which is caused by some organisms called fungi. These organisms can be either very tiny in size or very big in size sometimes. Usually they are transmitted between someone to another through close contact. So it's transmitted through close contact. Okay? Okay. Look, if he asks you how could I catch it or how did I get it, we said about close contact or touching items which have been in contact with the affected person, like towels or linings. But in your case also it could be due to the animal, the pets that you're having. Your cat could carry it to you as well. So I suggest that you take the cat to the vet. Why to take the cat to the vet? To treat it. Otherwise the infection will be back again to you. So one line of the treatment is treating the cat. Is this silly? Yes, this is silly, but it's important. What are you going to do for me? You'll prescribe him some antifungal cream. Just remember one antifungal cream, very enough. Clotrimazole. Clotrimazole twice daily for 4 weeks. Clotrimazole twice daily for 4 weeks. We may also prescribe some steroid creams for the first 1 week. Hello everyone, can you hear me? Can everyone hear me? Okay. So, because I was just having some instability in the connection. So, you will prescribe for him also steroid cream for 1 week. He will take it alongside the antifungal. Why? To reduce the inflammation. Very important to say that because it's going to reduce the inflammation that you're having. Okay, this is only for 1 week. Special advice, he will ask you if his wife is going to be pregnant. I'm sorry guys, just some connection instability from time to time, it happens and it's healthy. So he will ask you, doctor, what about my wife? She's pregnant. What she can do? You will tell him that usually this is less infectious. I mean, can be infectious only in case that we do not wash our hands and we don't clean our skin regularly. So we are going to advise him to wash the hands regularly and do not share linings or towel with her. Okay? Always ask these questions. Okay? Okay. Always ask these questions, guys. Or always say the things right. Do not share towels and do not share bed linings with her, and wash your hands properly and carefully. And please try to cover the affected area, to avoid the spread of it. Those are the general advice, and always advise her to always wash her hands regularly to avoid the transmission of the infection. Okay? Okay. So this is a station so far, very important station, but his only concern is that is it going to be transmitted to his wife or not? Okay.
Excuse me, brother.
Yeah.
I think this station also includes the involvement of a child. I would say.
No, this is a herpes zoster.
Okay.
This station, you mean the child, the small child?
Yeah, no, I think either the wife is pregnant or maybe he will ask that will it transmit to my would-be child.
Oh, if he asks you this question, if he ever asks you this question, that it will be infectious to his like unborn children yet. I mean the children to be born. Let's say that it is temporal infection, and it usually can be cleared away by washing the hands. So don't worry about that. So it's not like sexually transmitted. It is just skin contact infection. Okay. Okay. Like any fungal infection, it is usually local skin contact infection. Okay. Let's move to one station. I love this station, the Guillain-Barré. This station, Guillain-Barré, is very concise and the management is very easy. Okay, the management is very easy in this station, and you are FY2 working in GP. The patient is presented with some weakness. Okay, again, the patient is presented with some weakness in both sides of the body, both legs. Okay, so weakness in both legs, weakness in both legs, and she has got some concern. Talk to her and address her concern. Okay, so again, you're FY2 in GP. This will make a difference in your management. Okay, now move to the patient. You will find that she is a middle-aged patient actually. How can I help you? She will tell you that she's having difficulty in walking or difficulty in moving. Tell me more about it. She will give you difficulty in walking, which started like 5 days ago or 2 days ago. Okay. At first, her feet were weak, and now her legs are weaker, and her hands as well. So this is ascending weakness. It started with the feet, it moved to the legs, and now involving the hands as well. Anything makes it better, anything makes it worse? No. Sometimes she can give you also some history of numbness and tingling. Started at the same time. Okay? Okay. So now you have a history of ascending weakness. When there is ascending weakness, usually, definitely you suspect Guillain-Barré. The first thing which comes in your mind. For the Guillain-Barré, there is generalized body pain, and sometimes there can be back pain. So always ask the patient, do you have anything else? Like what, doctor? Do you have any back pain? Sometimes she can give you, yes, doctor, I have back pain. Okay, elaborate right now the back pain, like Socrates. The back pain started at the same time as well, and it has been continuous, and it's getting worse. Okay, what are the associated or what are the red flags here? The red flags are the complications of Guillain-Barré. Like what? Difficulty in swallowing, difficulty with breathing, difficulty in eye movement or vision, and visual problem. Those are the red flags. Difficulty in swallowing, difficulty in breathing, difficulty in vision, and difficulty in swallowing. The red flags, which can kill any patient or can give him blindness. Also, some bowel problems like urinary incontinence or problem with passing stool, like inability to pass stool. So bowel problem and urinary problem, beside the other red flags as well, are the complications of Guillain-Barré. Past medical history, or sorry, your differential diagnosis first. Differential diagnosis is a stroke. You can also speak about infection as well. And you can also ask about the myasthenia gravis. How to ask about the myasthenia gravis? In a specific time of the day, this weakness comes, she will tell you, doctor, it's all over the day. And when it comes to the post-medical history, very important to ask her about any fever or flu-like illness recently, because she had fever. She had flu-like illness recently, which is a trigger factor for the Guillain-Barré syndrome. Okay?
Can you repeat it a bit?
Upper respiratory tract infection. It is a trigger factor for GBS, Guillain-Barré syndrome. Usually Guillain-Barré comes after trivial infection, or trivial illness like the fever or flu-like illness. Okay, now you will ask some questions in the past medical history, like, do you have any other medical condition? No. Do you have any high blood sugar? She will tell you no. Do you have any high blood pressure? No. Do you have any what can I say? Do you have any stroke, or do you have any stroke or problem with your brain before? No. Okay. Move to the lifestyle. Lifestyle is important. Why? There is peripheral weakness, so I need to ask about alcohol in details and about diet as well. So do not forget to ask about alcohol and diet if there is any neurological weakness or peripheral weakness. Now move to the examinations. Please verbalize the neurological examination and be specific. I need to check the motor and sensory examination. The examiner will give you motor impairment everywhere, like difficulty in walking, and also he will give you some hypotonia and hyperflexia, and he can give you, or he cannot. Sometimes he give you loss of sensation in the lower part of the leg. Investigations, the examiner keeps quiet, which means that he needs you to tell it to the patient. What's going on? Guillain-Barré syndrome. Please, I need someone to pronounce it for me. Someone who can volunteer and tell me Guillain-Barré. Who can tell it to me? This may sound awkward too much inside the cubicle. I know some people who went to the exam and the only trouble they made that they could not pronounce Guillain-Barré. So I need someone especially from Pakistan or India to pronounce it for me. Say it to, no, not Pakistan, someone from Africa. Dr. Afodali, help me with that. What is the name of the condition? Dr. Afodali.
Guillain-Barré syndrome.
Again.
Guillain-Barré syndrome.
Yes, by the way, you are the best one from Africa who pronounces it, because I have been practicing with many people from Nigeria and all of them could stumble in it. I don't know why. Okay, so Guillain-Barré syndrome, or in worst cases, say Guillain-Barré. Okay, so this is a condition in which there is a weakness in the muscles of the body due to problem in the nerves supplying them, secondary to the infections that we have. Which infection, doctor? Actually, what happens is that our immune response to the body infection sometimes goes the other way around. Instead of fighting against the flu bug, it can fight against our own tissue. In your case, it fought against the outer sheath of the nerve supplying the muscles. That's why, and by producing some substance we call antibodies. So here it produced antibodies against the outer sheath of the nerve supplying the muscles. This causes weakness in the nerve and consequently weakness in the muscles. What will you do? You will send her to the hospital immediately to be seen by neurologist. Why? Because of the complications can occur at any time, like swallowing problem, like breathing problem. Sometimes it can progress quickly. Okay? Okay. What will be the treatment, or what will they do? Number one, they will start you some investigations, like lumbar puncture and electromyography. Lumbar puncture and electromyography. Okay? Again, lumbar puncture. Why lumbar puncture? Because actually in the lumbar puncture, they can find some elevated white blood cells, especially lymphocytes. Okay? Okay. And high protein as well. So in the CSF, they can find high lymphocytes and high protein, which basically points toward viral infection due to the flu. And also electric tests like electromyography or nerve conduction test to assess the damage to the nerve and the muscle. Okay, okay. What will be the treatment? Immunoglobulins and the plasma exchange. Immunoglobulins injection, the antibody to boost the immune system. And plasma exchange to filter the plasma from the harmful antibodies which is developed to our own nerve tissue. So number one, something to filter the plasma from the antibodies, Number 2, give strong antibodies to boost the immune system. Number 3, if she is having pain, this could be what we call neuropathic pain. Guillain-Barré is associated with neuropathic pain, so we can give her gabapentin. Okay? Okay. Is it serious, doctor? Well, usually many people or most of the people will make recovery. However, sometimes it can be fatal if not caught or if not spotted early. But the good thing is that we came back early. So we need to keep you and we need to give you the medications before developing any of the complications. Like what? Like breathing problem or swallowing problem. Are there any long-term complications? Like any neurological problem, muscle wasting, difficulty walking, some weakness, some speech problem, like any neurological problem. Can I call my husband? Yes, definitely. You definitely call your husband because you need his support right now beside you because she is going to be admitted in the hospital for a few weeks. This is the patient. I like it. You can finish it in 5 minutes or 6 minutes. No much details here. Now we will discuss 4 more stations quickly. We are done with the Guillain-Barré. What we will do right now, rheumatoid arthritis and Gilbert syndrome and alcoholic hepatitis and normal hepatitis. We will be remaining with rheumatoid arthritis and polymyalgia rheumatica and the confused man. Do 3 stations, we'll discuss them early. We can even start our session tomorrow earlier, like 15 minutes earlier. So that we discuss these stations. And after that, we'll move to the ethics station, the big game. Okay? Okay, no problem, Dr. Safa. Masi, the voice is not clear, seriously?
Your voice is clear, but I'm not able to hear it clearly. I don't know why.
Wait, guys, is there anyone else having problem with my voice?
I don't know, maybe there's some problem from my side.
Okay, no problem. Usually this session is recorded as well. But guys, again, anyone who is going to receive a recorded voice, this will be like an exception for some reason. And please guys, these videos or these voice records are not for share under any conditions. You know, only in one condition is that you are going to share it for yourself to listen to it later. Do not share it to anyone else. Never share it to anyone else. Okay? This can cause me some troubles later. I'm doing it for your own sake because I do not want anyone to miss anything. I know I'm not speaking in full details, but at least these things can be like very good mind mapping to you and very good review to you and very good like to show you the right approach, how to approach the station and how to answer and how to tackle any issue. Okay? But please do not share them to anyone under any condition. Okay? Okay, guys. Okay, no problem, Dr. Messi, but please next time make sure that we set your voice or your audio settings. No problem, Dr. Messi. You will receive this recording and you will listen to it again. I mean, you will listen what you missed. It's always the same, seriously. I think maybe it could be from your connection. Okay, we'll talk about this later. We can talk about this after I finish up my session. Okay? Will you be awake? Okay. So let's do 4 more stations. The first one is, 3 more stations. The first one is Gilbert syndrome. In Gilbert syndrome station, you know, the only finding is that you will find what you will find? You will find here that um, there is only one finding in the test results, which show that there is high bilirubin, unconjugated hyperbilirubinemia. This unconjugated hyperbilirubinemia, what it means that there is problem with the excretion of the bilirubin, or sorry, one problem with the conjugation of the bilirubin, which means that problem with the liver, right? So basically, this is a problem in the liver. Problem in the liver again. Okay? Okay. So, unconjugated hyperbilirubinemia and what else? Let me check the other test results that were given. Okay, so this is unconjugated hyperbilirubinemia, and as well there could be elevated ALT. Could be elevated ALP. ALP could be elevated as well. So the more important thing is unconjugated hyperbilirubinemia. The bilirubin is high. It's only unconjugated hyperbilirubinemia, Dr. Muniba. The unconjugated bilirubin is 39. Yeah, the rest labs are normal. I'm sorry, I did not see that. So he will ask him, how can I help you? He came for test result. Why did you do them? This is normal checkup. Why did you come for the checkup? He will tell you, doctor, that his wife, or he can simply tell you from the beginning, I came for the checkup because my wife is concerned and she thinks that I'm having diabetes. May I know why you think so? Why you think that? Why she think that you're having diabetes? Okay, she simply thinks so because she just cares about him. He doesn't have any symptoms. For example, do you have any tummy pain? No. Do you have any? Do you go to the loo more often? Do you feel thirsty these days? No. So basically, this patient is not having any diabetes. Okay, now you know from the test result that he's having unconjugated hyperbilirubinemia. So now ask about the things that worry you. Like what? You can ask about, number one, any yellow discoloration in the skin, jaundice. Okay, this jaundice is important. You can also ask him about any loss of weight. Loss of weight is still one important thing as well. Okay? Okay. Ask him also about any anemia symptoms. So again, jaundice, anemia symptoms, and loss of weight, which are symptoms of hepatitis or liver cancer. Jaundice, anemia, and the cancer symptoms. And loss of weight. What are your differentials here? And by the way, all the symptoms are negative. Differentials here are diabetes, okay, and hypothyroidism. Diabetes and hypothyroidism. Okay, those can be presented with tiredness and can be presented as well with some liver problems. Okay, in the past medical history, you can ask him about any fever or flu-like illness. You can also ask him about any blood transfusion because this is one risk factor for the hepatitis. And ask about any family history of liver problem. Lifestyle, you can ask about it normally. You can also ask about the job. You can take a bit of sexual history because sometimes unprotected sex can transmit hepatitis. Like, are you sexually active? Is it a stable relationship? Do you practice safe sex? Very simple. I would like to do some examinations. All examinations are normal, including tummy examination. You only do tummy examination apart from the vital and general physical. I'd like to do some investigations. Okay, the examiner keeps quiet. Test results here, or you will tell him that now we have done the test result. Yeah, I'm sorry. The family history was positive. I told you to ask about the family history of liver problem. He will tell you, yes, doctor, the father was having a condition in the liver. He would just tell you that his father was having liver problem. The father was having liver problem, but he will not tell you about the name of the condition because you will pick it up if he tells you. So he will tell you only the father was having liver problem. Okay. Now, move to the management. We did test result and it showed that you're having high bilirubin, unconjugated bilirubin. What is bilirubin? It is a yellow dye produced due to the breakdown of the blood. Supposed to be conjugated and excreted by the liver. In your case, it's high. And also, there is another enzyme which is the ALP is high. It's mainly concentrated in the liver. Why they are elevated, doctor? You will tell him that they are elevated usually in case of any liver problem. What could be the cause? If he asks you what is the cause, you will tell him that it could be a condition called Gilbert syndrome. What is this? It is a genetic problem, faulty gene in the liver, which is responsible for the conjugation and the excretion of bilirubin. Okay? Okay. So it is a faulty gene which disables the liver from excreting the bilirubin from the blood. That's why the bilirubin is elevated in the blood. And it is basically inherited condition because your father is having it. He will ask you, why didn't I have any symptoms before? You will tell him that usually it's asymptomatic and many people can live and die without experiencing any symptoms. It can be only discovered accidentally while a checkup. What will you do for me? You will refer him for further investigations or further tests. Okay? Which test? Liver function test and ultrasound scan or CT scan of the liver. Sorry, liver serology and ultrasound or CT scan of the liver. Okay, he will ask you one question, will my children get it? Okay, at this point actually you will tell him that it runs in families. Okay, and it can affect men more than women. It can affect more than women. Okay, however, usually it's asymptomatic. It doesn't cause any symptom unless under certain conditions. Like what? Like stress, lack of diet, lack of drinking water, under some infections, like when he's having infection. In these things, if you notice any yellow discoloration or tiredness on your children, please bring them to us. Lifestyle advice. Lifestyle advice is usually if you experience any symptoms, please make sure to know the trigger that causes these symptoms. Like what? If your symptoms are triggered by stress, then try to avoid it. If they are caused by infection, so it's better to treat any infection as soon as possible. Maintain healthy, balanced diet, proper sleep, eat and drink well, and drink enough water. This is the station. So basically, Gilbert syndrome is asymptomatic and it is hereditary. It can be also transmitted to the children, okay? That's why we can test them for you. However, if you notice any yellow discoloration on them, come back to us. We will refer him to specialists for further test as well. Which test? Liver serology and scan, ultrasound and CT scan. Okay, okay. What else? Next station is the alcoholic hepatitis. The alcoholic hepatitis simply, it is one of the stations in which the liver enzymes are high as well. Okay. So one more question is that I forgot. If you were asked, or if he told you, doctor, I do not have any children for the Gilbert. I do not have any children, but what if I'm planning? At this point, you'll ask him to bring his wife back to be tested and to see the possibility of his children catching the Gilbert syndrome. Okay, by the way, Gilbert syndrome can be sometimes autosomal recessive and it can be sometimes autosomal dominant. So just say that bring the wife to test her and to see the chances of your children to be infected. Okay. One other station is the alcoholic hepatitis. Why alcoholic hepatitis? Alcoholic hepatitis is simply like the normal hepatitis, but they brought it for one reason only. They brought it to confuse you in the liver enzymes. Okay, let's discuss the two stations together to save our time. Okay, I told you we will be left with only rheumatoid arthritis and polymyalgia rheumatica and confused man. 3 stations, we will discuss them early before starting tomorrow, before moving to the ethics. And in the ethics, we will discuss 15 stations tomorrow in the ethics. 15 stations, we can even end in 2 hours in the ethics. So the most boring part in the session or the class has been over, the medicine. Okay. In the alcoholic hepatitis, it is similar, very similar to the normal hepatitis, but with one difference. Here, in the alcoholic hepatitis, the ALT is quite high. ALT, alanine transaminase, is quite high, but the AST is normal. While in the other hepatitis, both enzymes are raised, but mostly ALT, mostly AST. Again, in the alcoholic, the ALT is quite raised in the alcoholic. But in the viral hepatitis, or in the hepatitis generally, the normal hepatitis or the infectious hepatitis, both are raised, AST and ALT, but the AST predominantly. Okay? One more thing. In the test result here, in the alcoholic, the MCV is high. MCV is high, you know what this points? This points to long-standing alcohol consumption. Long-standing alcohol consumption. Okay. So, the difference between the two stations is that in the viral hepatitis, she's coming for her test results and she was having episodes of, could be tummy pain, episodes of vomiting. Okay? Okay. But in the alcoholic hepatitis, they are asymptomatic. He just came for the routine checkup, job checkup. Okay. So for the alcoholic hepatitis, you'll ask him, do you have any symptoms? Like what? Like symptoms of the hepatic problem. Do you have any yellowish discoloration, jaundice, anemia symptoms again, any cancer symptoms again? You'll ask him also about any diarrhea, any constipation. Okay. Sometimes he can give to you some tummy discomfort. Some tummy discomfort. Why tummy discomfort? Usually this tummy discomfort is sort of GERD. This is GERD due to prolonged alcohol consumption. So please make sure that in any hepatitis or any problem with the liver, you ask about number 1, tummy pain, number 2, loss of weight, number 3, loss of appetite, number 4, anemia symptoms, and number 5, nausea and vomiting. Okay, this tummy discomfort here that is going to give you points toward the GERD, the reflux. Why reflux? Due to prolonged alcohol consumption. Okay. Now, what are your differential diagnoses? Cancer, right? Anemia, as we said, we asked about both of them. You can also ask about the blood transfusion in the past medical history. You can ask about any recent infection or recent hospitalization or recent surgery. Any hepatic problem, always ask about recent infection, recent surgery, or recent blood transfusion. Also ask about family history. Why? Because hepatitis can be transmitted between blood-borne infection. Now move to the core, personal history or lifestyle. In the lifestyle, it's very important to ask about the diet. and ask about the alcohol. The alcohol is the core of this station. He will tell you that he has been drinking 2 bottles or 1 bottle of wine every day. Too much. 1 bottle of wine every day. Okay? Okay. Now you know the reason for his problem, right? Okay. Move to the examinations, or to first ask about some sexual history again. Why? Because in sexual history, one of the reasons of transmitting hepatitis is the sex, especially unprotected sex. Do some examinations, including the tummy examination. All of them are normal. Do some investigations, the examiner will keep quiet. What you can do right now, you will disclose the patient the test results, showing that he is having the enzyme which is called the ALT is high, which means that he's having problem with his liver. Why did I have this problem? You will tell him that it's usually because of the alcohol of your alcohol intake or your excessive alcohol consumption. Well, how did you know, doctor? You will tell him about the result of the ALT and the MCV. Both can be high in the case of alcohol intake. Okay? Okay. So, what are you going to do for me? We are going to do further investigations for you. In any case of alcohol or any hepatitis, number 1, you do hepatitis serology. Number 2, you do hepatitis or scan. Like what? Number 1, liver serology, or hepatitis serology. Number 2, ultrasound and CT scan on the tummy. You can ultimately, if he shows any symptom, you can refer him to specialist to perform some sample from the liver. So again, serology, CT scan, and refer him to specialist ultimately to perform sample. Meanwhile, you can do some other things. And by the way, do not forget also to measure the level of vitamins. Beside the hepatitis serology, measure the level of vitamins. Why? Because there is a strong association between the alcohol and the vitamin B12 deficiency. Okay, so again, hepatitis serology and vitamin. Number 2, scan. Number 3, refer to specialist for sample. Okay, now address the issue of the alcohol. Tell him, meanwhile, you need to do some things. Your problem is due to the excessive alcohol consumption. Have you ever thought of cutting it down? He will tell you no, but you need to cut it down because of this. So have you ever felt guilty about your alcohol? You know the KHDWT question. KHDWT from psychiatric history. Why? Because I need to assess his addiction or his risk of alcohol intake or alcohol consumption. It's very simple. If I ask him about have you ever thought of cutting down, and I need to assess his dependence on alcohol by asking him if he is able to perform his daily task without alcohol, and if he experiences any withdrawal symptoms if he stopped alcohol before, and if he needs to increase the alcohol, the amount of alcohol to reach a similar effect. Okay, this guy is quite dependent on alcohol. So right now, actually, what you can do, you can tell him that it is important that you drink in moderation. By the way, he's not, from the finding that he gave so far, he's not having bad alcohol dependency. You know, he was just drinking since long, but he did not experience any withdrawal symptoms or did not experience anything else. Okay, the thing is that here, this guy is asymptomatic, which means that you do not tell him that it's advisable that you stop alcohol because he's asymptomatic. He doesn't have any symptom. You will just advise him about to drink alcohol in moderation. How moderation? Just tell him 14 units per week are quite enough. 14 units per week of alcohol are quite enough. And we can refer you actually to alcohol dependency clinic or alcohol dependency colleague, the psychiatrist. Why psychiatrist? They will refer him to Alcohol Anonymous if he tries to cut down. So again, it's advisable to drink in moderation. And if you consider cutting down, we can help you with that by referring you to one of our colleagues, and they can offer you some medical and non-medical options. Just say that. We'll come back to Dr. Evera. Okay, okay. Then advise him about healthy, balanced diet because alcohol can affect his vitamin level as well. This is a station, very simple station. Routine bloods, serology, CT scan, and ultimately you can refer him to specialists to perform sampling. Okay, advice number one, drink in moderation. Have you ever thought of cutting down? If you ever thought, we can refer you to one of our colleagues. He can help you by giving some medical and non-medical options. Number three as well, you will advise him to maintain healthy, balanced diet. Why? Because the alcohol will affect the vitamin level. Okay, the last station for today will be the normal hepatitis. It's quite similar to this one, but the thing is that she is symptomatic. So means that the new one is easier and shorter. The hepatitis, the normal hepatitis, she is having tummy pain. Okay, this lady or this girl is having tummy pain. Okay, okay. So you will elaborate the tummy pain, and she was having some episodes of nausea or vomiting. Okay. She had some episodes of nausea and vomiting, elaborated the nausea and vomiting, and it's very important to ask about the associating symptoms. Which are the associating symptoms again? Again, guys, she's having this problem since 2 or 3. She's having this problem since a few days. Okay, since only a few days, which means that you need to ask her about maybe any diarrhea, any fever, any constipation, any change in your urine or stool. Dark urine or stool are characteristic for jaundice as well. So she's present with stomach pain and sickness or nausea vomiting. Elaborate both things and ask her about the other complaint like fever, like diarrhea or constipation, like any change in urine or stool. Okay. What are your differentials here? Actually, you know from the test result that this is viral hepatitis and this is acute case. So your differentials could be alcohol. You'll ask in the lifestyle about the alcohol intake. You'll ask also in the PMH about the family history and the blood transfusion again and the hospital stay or recent surgery. You can also ask about the cancer. Rule out the cancer. Again, cancer and infection and family history and the blood transfusion and surgery. Lifestyle, very important to ask about the alcohol and the diet. When you ask about the diet, you'll find that she ate outside 2 days ago again with her husband. Okay, okay. Then take some sexual history because the hepatitis can be bloodborne actually. Very important as well. Same examinations including abdominal. The examiner sometimes will tell you that the patient is having jaundice and there's mild tenderness on the right upper quadrant. Usually in the acute infectious or inflammatory hepatitis, there is tenderness in the site of the liver. And in the investigations, okay, the investigations are similar to the task. The task would say that for FY2 in medicine department or GP, and the patient is coming for test results. What are the test results here? The only difference is that the ALT and AST, both of them are high, and the AST is predominantly high. So if you want to say in the investigations, you'll tell the examiner, I need to do hepatitis serology. Hepatitis serology. He will ask you why, doctor. To say that because I need to look for hepatitis A antibodies. So here you are suspecting hepatitis A antibody because of her diet and because of her acute symptoms. Yet in your history, you have to rule out blood transfusion and IV drug abuse or tattooing or piercing and recent surgery or hospital stay and sexual history as well to rule out other causes of hepatitis as said doctor. The examiner, he will give you hepatitis A IgM is found, which means that this is acute hepatitis. Disclose the test result. You will tell her that this is because of a problem in your liver, the sickness and the tummy pain. Upon our test, we did some tests which show that there are raised enzymes ALT and AST, which can be raised in case of hepatitis infection. And we did also some serology to detect the amount of antibodies. What is this? Which can be released against the infection. And it was high and conclusive for hepatitis A. Sometimes he will not give you hepatitis A IgM. So just say that we are suspecting that it's because of hepatitis A. Just say we are suspecting. However, we need to do some further tests to confirm the reason or the bug. Okay. How did I get it? You will say from the food, usually through uncontaminated food. Okay? Okay. What should I do? You will tell her that this is simply self-limiting. However, again, like the food poisoning, okay, you can take some anti-sickness medication. Stop drinking alcohol. And but here we do not advise to take painkiller. Why? Because usually there is liver affection. However, if she wishes, paracetamol can be taken. Okay? Okay. She will have some concern regarding sexual intercourse. Can she have sex? Okay, here it's advisable to abstain from sex at least for 1 week from now. So 1 week after the start of the symptoms. And bring your husband to take the hepatitis jab. Can I transmit it to other people? Yes, it can be transmitted to other people. So what to do? Again, avoid sharing towels, wash your hands carefully, avoid preparing food for others, and avoid sharing utensils with others. She will ask you, shall I stop taking seafood from outside, especially from restaurants? You will tell her, actually, this problem or this condition can be transmitted through the uncontaminated raw food, especially the seafood. So it's advisable to boil the food and let it steam under 90 degrees Celsius. Steam at least under 90 degrees Celsius to be boiled, or steam under 90 degrees Celsius to kill the bug. So basically, she cannot have sex till 1 week from now. And going to the school, she cannot go to the school because she's a teacher. She cannot go to the school at least for 1 week from now till the symptoms subside, or at least till the symptom ease. So it is self-limiting condition. Within 2 or 3 weeks, it can go. Okay. And she abstained from sex for at least 1 week after start of symptoms, and abstain from the school for 1 week after start from symptoms. And she better bring her husband to be vaccinated and receive the hepatitis jab. Okay? Okay. Boil and steam the food under 90 degrees Celsius to kill the virus or to kill the bug. Okay? General measures: avoid sharing towels, avoid sharing utensils, and take simple painkillers. This is today's station or today's session. We are left with 3 stations: rheumatoid arthritis, polymyalgia, and confused man. We will discuss them tomorrow before the beginning. Mostly we will start tomorrow 15 minutes earlier. Okay? And for today, please, I need some of you to practice with each other, at least today or tonight or tomorrow. I know that all of us are tired, but it's better to agree with each other on the WhatsApp group. So everyone will practice with the other person. I need you to arrange, like do not set yourself into groups. For example, right now, Dr. Mahdi can practice with Dr. Safa. Tomorrow he will practice with Dr. Rumi. Tomorrow he will practice with Dr. Murad, with Dr. Muniba. So it will be like a cycle. So please make sure that you rotate and cross over each other, especially in the morning, because in the night all of us are tired and exhausted after the session. So it's better to read in the night and practice in the morning. This way you will cover, not practice everything, but at least 5 stations, 5 to 6 stations at least. This means that you will practice at least half I will practice at least maybe 100 stations by the end of the course, or maybe 90 stations. At least you will practice each or one station from each set. Okay. Okay. So you can arrange it on the WhatsApp group, guys. I can arrange it for you, by the way, on the WhatsApp group. Just give me a few minutes from now. Okay. Okay. Thank you all for listening today. It was a very long session. You know, we covered at least 20 stations today. 20 stations is a big deal, seriously.
Dr. Ahmed?
Yeah?
Just regarding alcoholic hepatitis, is it a counseling station?
The alcoholic hepatitis, well, he came for test result, but this, hello?
Yeah.
Can you hear me? Dr. Zaid, can you hear me? Dr. Zaid? Hello? Hello?